Hello, and welcome to another episode of Talk on Things and Stuff. Now, if you've been paying attention to the channel for the past several months, you'll see that I've been putting recordings from various state hearings as either subcommittees within the House of Representatives or the Senate or the medical board have convened to hear testimony on both sides of a very important issue that is confronting our nation. And that is whether or not we should transition children with gender dysphoria. And that therapy could take the shape of either puberty blockers or cross-sex hormones or surgery, which may include double mastectomy for young biological females or various other sex reassignment surgeries. Now, if you take the time to go and listen to each of those testimonies, you're going to hear proponents that are usually in the form of clinicians in the state itself or experts from outside, but you'll also hear parents and you'll hear detransitioner stories, people for whom that whole medical process went wrong or whose families were severely or significantly affected by this issue. And I realized that there were very few channels where those video sessions were made really available. So I started looking for more and came across the Ohio SAFE Act hearings. This is House Bill 454 in Ohio. The hearings were held last year in February and several months after that over a series of sessions, hearing from both proponents and opponents of the bill. Each of them would come up and give a testimony and then answer questions from the members of the committee. And initially, my thought was, I'll just get these recordings and throw them up on the channel without any further ado. But as I started to listen to them, it came very clear that this was an excellent framing for trying to understand all the different sides of the issue. One of the parents in particular who bore testimony in one of these hearings stood out as just a phenomenally powerful voice. And I recognized the name because they have been active in kind of gathering support for parents who are dealing with this issue. And that is the voice of Jeannette Cooper, who I would like to invite onto the stream today. How are you doing, Jeannette?
I'm doing well. Thank you so much, Jonathan. I appreciate it.
I just have to say, like, you're listening to these testimonies and there's people coming in with some of them very emotional testimony, others trying to be very factual driven. And then you arrive with just like such intensity and focus.
Mhm.
And one of the first things that you set out doing is saying, this is not a partisan issue. I'm here with my father, but we, from both sides of the political divide, see that there's a problem here and we need to address it, see how it's affecting both the individual's lives in terms of the kids, but in the wider family and society as well. Can you give us a brief summary of just how you got into this issue and what it was that led you up to that moment in these hearings?
Yeah, I grew up in Ohio. My mom's actually from Chicago, which is why I settled here, but a Midwesterner for sure. My dad still lives in Ohio, North Central Ohio, and my parents are divorced. I had heard about House Bill 454 from another parent who had been involved in educating Gary Click, the representative who introduced the SAFE Act. So I knew from her kind of the background of what was going on. My own personal story is I've lost custody of my daughter who was diagnosed with gender dysphoria now 3.5 years ago. I guess the synopsis is that she went to her dad's for a visit and she never came home. I used to have her 7 days a week, 6 nights a week in terms of custody. After my divorce, we went to family court to enforce custody. And then they put a temporary order in place for her to stay with her dad while they investigated why she was saying that she didn't want to come back home to our home. And I was fine with that. And then that temporary order became permanent, mostly around two beliefs. Some people can't quite understand how somebody who used to sit on the school board and was a teacher for many years could possibly lose custody of her only child. And it's two strong beliefs. One, there is such a thing as a transgender child and they are born that way. And if you don't affirm them with what is actually a psychologically positive reinforcement through the affirmation model, they are either more likely or very likely to kill themselves. And if you believe those two things to be true, then of course it follows that you would not have a child return to a parent's home who is not providing that positive reinforcement of the idea that they are born in the wrong body or that there's something wrong with their body. So that's how I lost custody of my daughter. Right now, it's been 3.5 years. So, concept of gender dysphoria and how that comes into the family court system in a way that sounds like it's medical, that sounds like it's psychological, that sounds like it's a treatment that your child absolutely needs in terms of the affirmation model. Showed up in my case, it shows up in other cases. That's my own personal story. And then, of course, my father has been impacted by this. Of course, I have the only grandchild of the entire family. That's true on my ex-husband's side also. My dad is now, I think he's going to be 77 this year. I'm going to say he's in poor health, but he's 77. And so he and nobody else has access to my daughter at all. It's awful. I don't know how else to describe it. It's awful. It's not healthy for her as a child to have that disconnection and a complete recreation of her life story in a weird way. It's unfortunate. I was happy to participate in the Ohio hearings, even though my story is pretty unusual, not so unusual. I know other parents in my situation.
Yeah, no, that question of child custody and this issue is coming up more and more frequently, especially as child protective services, as healthcare, mental health care professionals have just made those assumptions that you talked about, then they only see the safety of the child as being able to adopt this ideology. There's kind of the absent question from that, which is that even if you assume all of those things to be true, there's another assumption that is invisibly carried across, which is that the assumption is that if you do all of those both social and medical
Mhm.
affirmation and transition therapies, then it means there's a less likely chance of suicide. And that question itself has not been established. That conclusion has not been established. There's even some evidence that points that it actually may make it worse. Just because you get the therapy, get the surgeries, those changes made, doesn't mean that suicidality decreases or that there's a less rate of suicide. And that is what we're seeing change direction in some places across the globe. But I appreciate you sharing that perspective for us. You're going to meet both you and your father as we go through these series. I think your child's grandfather's
Mhm.
story is really compelling. You can really hear the love and concern that he has. But with that said, my proposal to you, if you're okay with it, is that we
Yeah.
go through each of these testimonies and give a little perspective because while I'm listening to it, I'm thinking, but there's so much more that you could say about this, or they're forgetting this particular study. And I wanted to take the opportunity to go through that and see it. And if you're on board with this, if we can go through each of the different testimonies over the next few weeks over a
Yep.
series of interviews, I think that we can add some insight and perspective that'll be helpful for people trying to grapple with this issue. Does that sound good?
That sounds great. I will preface this by I train parents a little bit on how the legislative process works and
Mhm.
how legislators are given, like the people in family court, are given a pretty narrow set of information. They can't possibly know everything about every bill that's introduced, even the ones that they themselves are introducing. It's very complicated to become an expert on a topic in order to educate other legislators who have other bills that they are introducing and they are considering.
Mhm.
It's very
Yeah.
complicated. So at the end of the day, each legislator in their voting on the most basic level is looking for the obvious answer. What is the obvious answer? What should we actually do? What's going to be helpful for the populace? So we want to make the answer obvious to the legislators. That's a little complicated in this issue, and I think we're still trying to figure out a way to make that answer obvious to the plethora of information that we all know as parents or as people involved in this issue. It is a little bit complicated to that download all of that in a series of a few hearings.
They did a pretty good job, and we're going to try to make that even more clear so that my understanding is despite all of this effort, the SAFE Act did not make it outside of this hearing. And so it's an issue which may show up again in the next legislative session. Is that correct?
It is correct. It will be
Okay.
reintroduced under a new number by Representative Click, and yeah, I have talked to him, and there's other SAFE acts and similar acts being introduced in legislatures across the country, and we're watching them.
Okay, excellent. With that being said, why don't we get started and dive into the very first witness testimony, which is Representative Click introducing the bill to the committee. So this is House Bill 454, also known as the Save Adolescence From Experimentation Act. And we'll get started with the introduction of Gary Click. And then I want to pause and maybe just do a little bit of profile of him and how he started in this issue. So let's go ahead and get started.
Ohio House Bill 454, also known as the Save Adolescence From Experimentation or SAFE Act. Families, Aging, and Human Services Committee. First hearing, February 17, 2022. Testimony by Representative Gary Click, proponent.
I will now bring forward House Bill 454 for its first hearing and would like to call on Representative Click to present sponsor testimony. I was going to say welcome to committee, but you already live here.
Thank you, Chairwoman. I sure appreciate that. Chair Manchester and Vice Chair Catrola, who's not here. And also, I apologize, Ranking Member Denson. I gave Representative Liston your job, but congratulations on filling that spot for now Minority Leader Rousseau, who's also done a fine job on this committee. And Representative Liston, I promise to give you the same respect I always have, even though you're not the ranking member. And Representative Humphrey, we certainly welcome you to committee. We're glad to have you here, along with Representative Smith, who obviously had to step out. Do you remember what it was like when you were a child? It's an honor to give testimony to you today, by the way, and I thank you, Chair Manchester, for bringing this forward. As children, we have many visions of things that we want to do. We might be someone like Neil Armstrong, who loves flight, and we dream about space, and someday we actually do go to space. And then there are many other people, though, who had that dream of being an astronaut, and they just become productive leaders of society in many different ways, different other areas and so forth. Because really, as children, childhood is a time of play, imagination, and exploration. It's where we can dream about many different possibilities, many different futures, and we can pretend to be whatever we want to be, and so on and so forth. So time is filled, or youth and childhood is filled with many of those things. And as a child, as a child with limited life experience, every circumstance seems to be immediate. Sometimes it's hard to imagine or to envision a life many years down the road.
Okay, so this is Representative Click. He's the bill sponsor. So I believe what that means is that some special interest groups, some parent groups, some concerned citizens approached him and said, this is an issue that's affecting your constituency. We would really like to see a bill that may be modeled after what some other states are doing to try to prevent school counselors, therapists, various people that our children are exposed to and that have stewardship over the children in conjunction with the parents from taking kids down a certain pathway. Does that kind of sum up how he got involved in this, or do you have any other insight into it?
So yes, there are special interest groups involved in pretty much every piece of legislation. And of course, there are just regular citizens who go to their representative and say, I think this is important. So of course, that's how the citizenry participates in the legislative process. So that's not a new thing. And of course, special interest groups they represent people. They're not coming out of nowhere. And so, yeah, they take an issue and they say, hey, representative, whoever, Click in this case, we're interested in doing this particular thing to protect, because generally legislation is introduced in order to prevent something from happening in many ways. Because in the United States, we have this idea that you can do whatever you want unless it's prohibited. So right now, the act is the Save Adolescence From Experimentation Act that was introduced in Ohio. And it is that Save Adolescence From Experimentation. That's what they're saying is happening. This is experimentation. And I think you'll talk more about that. This is medical experimentation. This is a bit of psychological experimentation through the affirmation model. That's never been a model that we used with psychological disorders. Basically, affirmation being positive reinforcement. And then certainly the experimentation on the actual bodies of human beings, including children. The Save Adolescence From Experimentation Act covers that. I think in this particular case, it was under 18s. Some acts vary. Representative Click included particularly the medical part of the experimentation of the treatment of gender dysphoria under some sort of medical intervention. And then there was a piece around the psychological, meaning the concept of affirming this child's idea that they are in the wrong body, for example, or that their concept of who they are doesn't match their biological sex. So yeah, that's all embedded in that bill, and it would have prevented people from doing that within government systems. So people who receive government funding, of course, hospitals, nurses, and psychologists, schools, people like that.
Okay, so I think it's good to have that on the table going forward, particularly the idea that it's no surprise that special interest groups, concerned parents are involved in getting a representative to bring a bill forward, because the idea that there are groups that are interested in this issue and behind the scenes working to help the representative put the best possible chance of making a legislative change in place is almost demonized by some of the questioning. And some of that demonization stems from some of the groups have a religious affiliation or a religious background. And so the idea is just because they are religious groups that are interested in this issue, then we cannot legitimize the issue or address it. And so that facet of it gets targeted either directly or as a question left hanging in the air. On top of that, it's really difficult when you're first starting this rabbit hole about understanding this issue because you're going to hear childhood, adolescence, puberty, full therapy, hormone, affirmation, social transitioning, medical transitioning. So I want to lay out some definitions, first of all. This entire discussion is confined to childhood, to minors. We're not talking about people who are above the age of consent. So regarding what adults may choose to do with transition, this has nothing to do with that. This is not trying to restrict or address that at all. We're only talking about individuals up until age 18. Beyond that, there's also a lower end, and that is that currently as it stands, there's no recommendation through WPATH or anything that young children receive surgical or hormonal intervention. So there are young children who are brought to the attention of medical professionals who are reported to have the experience of gender dysphoria. And currently there's no medical recommendation that those receive a medical intervention on. Now, the question of social transitioning as an intervention is something that has come up, but it is also outside of the scope of this because they're not explicitly preventing social transition as I understand it. Although there is some opinions from significant thought leaders, including Ken Zucker, who was in WPATH and was involved in shaping the care for a period of time. But his opinion is that social transition is a form of psychological intervention that contributes to increasing the number of kids who persist in their gender dysphoria rather than going through the normal desistance route.
I want
Go
to say
ahead.
a couple of things. So, in this particular SAFE Act, House Bill 454 in Ohio from 2022, it's true that it's talking about below the age of consent, under 18s. We recognize that children's brains are not fully developed on average around 25. So, you'll see bills in other states being introduced that maybe come around that age. Maybe they go to 19. So, the idea of consenting to something like this is one issue that is part of all of these acts that are introduced, including this one in Ohio. But I think if we're talking about psychological development of children and their capacity to make decisions, if we bring in the data on actual brain development, I think it does necessitate in some bills, some representatives see that it is necessary to bump that age up and to put other provisions in for the social or medical transition. So even the concept of children in law, we generally have that number as 18. But we understand that everybody is a child of someone. So I think the legal definition of child versus adult, it's not like you wake up and you're an adult at 18. We know that's not true. So that's
There's
one.
some precedent with this in the medical profession where some procedures, such as voluntary sterilization, physicians feel they cannot ethically do to someone until they are age 25 because of the very issues that you talk about, the full maturation and full development of somebody's cognitive capacity and ability to understand the ramifications extending to that age.
And I think we'll talk more, probably you'll talk more about the recent study about what you were referring to in Ken Zucker's analysis of social transition is really a psychological transition. The concept of affirmation is positive reinforcement in the most psychology 101 way. You positively reinforce a behavior, it's more likely to persist. Of course. So that's how we see people who are psychologically affirmed, socially transitioned. That's really a psychological change. That's basic behavioral modification where you do get more persistence. And then of course, if you have that persistence, you go on to some sort of medical treatment to then physically change yourself. That's true.
Okay. So there's another fundamental aspect to looking at this issue going forward, and that is there's an assumption on the side of a lot of these therapies that certain foundational things are true. And one of them is that people have a gender identity, which is apart from your physical body, and that it's this ineffable, almost metaphysical thing for which there's no scan, there's no diagnostic test, there's no blood test that can tell you what your gender identity is. It's something that comes out of the complex experiences and reality of your cognitive mind, but it's separate from your biology. And so that is a belief that some have said is almost a spiritual or a metaphysical belief. It's not anything that you can tangibly put your hands on. But it's a new type of belief if you step back and say there's another perspective for our experiences as humans, which is that we are our physical bodies, that we are, our whole person is an integration of who we are physically, and our mind and our expressions are simply who we are. We are not some separate entity that is driving a meat sack on a skeleton frame. We are our bodies. And so depending on what assumption that you hold there, you could either accept or reject the premise that all of these medical and surgical interventions have. And people that look at the history of this idea of a gender identity being something that's real and separate from your body will point to early researcher in this area, John Money, who coined the concept of a gender identity and engaged in some very questionable, medically, ethically unsound interventions in the lives of his patients, things that would never pass the muster of a legitimate IRB today, as well as an intersection with philosophical movement called queer theory, which takes this concept of a gender identity and blurring out all of the gender norms in society in a way that really facilitates moving forward in this. What's your perspective on those? Have you encountered those ideas, and do they play a role in the assumptions going forward?
Gender identity, what is that? Of course, it's this changeable over time based upon social and cultural context. And then, of course, our place in our moment in history of what do we think is the expectation of a man? What do we think is the expectation of a woman socially, culturally? And of course, that varies. So that's changing, of course. I know in the 20s, I super love the haircuts of the 20s of women, this styled kind of short around the face and these little dresses. And some of the women didn't shave under their arms. And it was quite progressive at that moment. And so it was a cool moment in time. And we can see how the concept of gender, for example, these women wearing different things or cutting their hair short, that changed our concept, this cultural social concept of what does it mean to be a woman, that thing called gender, which of course changes over time. The thing that you know and I know that our bodies do not.
Is the difference between the truly socially constructed aspect of things that we associate with particular genders that become the stereotypes, and then the biological reality of the sexes.
Yes.
And so, depending on how you interpret those issues, you could say, if you start with the stereotypical characteristics associated with the gender, then you could say that the performance or the affinity for those characteristics determines whether you're a man or a woman or a boy or a girl. So, if you have an affinity for pink, for dresses, for long hair, for things in our moment in history are associated with femininity, then if you're rooting your definition in the performativeness of that, then you'd say that's what makes a girl. And so if a child who is biologically male says that they relate to and are attracted to and appealed with all of those things of femininity, then you say, oh, this is a person who it should truly be, through gender identity, a girl. And that starts you down a whole pathway. Now, if you step back again and take it from a different perspective and say, we're going to start with the biological reality of what their biological gender is, then if you have a boy who has an affinity for all of these things that are stereotypical and culturally feminine, then you could just say, this is a boy who likes those feminine things. And if you tie that to a liberal sensibility that says that that should not be a problem, boys can betray those stereotypical norms. It doesn't change their biological reality, but we can have a society which really expands the possibilities of what it can be to be a boy, and that should be no problem. So those two different perspectives really change your outlook on it. And if you're a parent who is instilling values and ideas into your child, then you're going to shape them with those ideas. If you're a school teacher who makes one of those assumptions and you're seeing a kid for many more hours than their parents are, and you're having a significant influence, you can shape how that kid perceives their place in the world. And they could see themselves as, oh, even though I'm a boy and I like all of these feminine things, it doesn't change that I'm a boy, and I can continue to like those things and grow and learn. And maybe that'll change in the future. Maybe it won't. But either way, I'm fine. Or you could be take the other perspective, and the kid will say, I've got this now conflict. I'm biologically one thing and I really like these other things, which means I actually am something else. And then it creates a psychological tension that if every teacher, every therapist is reinforcing, carries this tension forth into all of the experiences that the kid has. And that is one thing to be aware of, I think, as we go through this. It's important to understand.
I think there are two things I want to say after hearing what you were saying. One is this assumption that somehow human beings do not grow and change over time. Sometimes, obviously, they do in very significant ways. So maybe, sure, a child who likes stereotypically feminine things for whatever reason that is, whether it's personality or just their environment. We talked about positive reinforcement. So if you're living in a household where it is positively reinforced and people are getting attention for playing with sequin dresses or putting them on, you probably put one on no matter who you are because you're going to get some sort of positive reinforcement for that. So when we see that, the assumption is that will be your life trajectory, that you will always like those things. And I don't know about you, but I didn't like peas as a child. I still don't. But there are 1,000 other things that I didn't like as a child and had a great aversion to that I quite like now. And the opposite is true of things that I disliked that I kind of like now. So that changes over time. That part of that is personality. Part of it is just time changes. And when time changes, it's the environment around you. And everybody is adapting to their environment. The second thing that I wanted to mention, besides the fact that human beings we change over time. And when that's always been true, some things stay the same and some things change. And we can't say which is which. Certainly not when a child is 7 or 10 or even 15.
Okay, those are good points. And it brings to mind one distinction that I've started to make very clearly will guide our distinction is when we're talking about these children that are the focus of all of this legislation, you could either call them trans kids, make that assumption at the front, changes your perspective on what we're doing, or you could say that they are children who are experiencing gender dysphoria. And that doesn't lock them into an identity. It doesn't lock them into a diagnosis. And it frees you up to be more open to seeing that there are different outcomes that may occur with children with gender dysphoria. You cannot slap the label trans kids on them and then go forward with that assumption. And so we're going to be very deliberate in our language and saying these are children who are experiencing gender dysphoria, and realize that the question of whether or not these are what are considered trans kids is a political question, and it's outside the domain of what we're discussing. There's another dimension to this entire discussion, which is the question of how much of a role should government have in dictating what the medical profession can do? And that means the government getting involved in decisions between physicians who are supposed to and assumed to be bound by their own medical ethical principles and the standards of evidence-based medicine. And should the state be able to do that at all? And you could take your opinion on the question of abortion and say, okay, that's an example of the state trying to or having historically had a say in a private medical decision. And what does that now what is the implications for that on this question? And for me, I tend to take a more libertarian perspective, which would want to minimize government interference in something like this. And I think the tension between that question is why some states, such as Ohio, we have the state legislation trying to draw boundaries on these therapies. And in other states like Florida, they asked the state medical board, which would affect the licensing of that state, to have an intervention, because in that case, it's the medical profession, those who oversee the licensing of medicine, who are doing their own internal safeguarding. And there's a fundamental difference there philosophically, and it comes up a few times in the debate around this question in Ohio. But I'm not quite sure where I fall on that line. So even though I would agree with wanting to have these safeguards, I don't know if the state or the medical profession itself is the right place to do that. And I do feel once you see the evidence, how flimsy it is justifying these therapies, I feel that the medical profession is failing their patients. And so if the medical profession is failing patients and doing things that are unethical and going to have bad consequences that you can see from outside of the medical profession, there can be some role, and we have some history of that. What's your take on that before we continue?
I think we can both agree that we have government for a reason. This isn't anarchy. What is the role of government? This is a giant question, right? Of course, we have to agree that the role of government we have some ability to impact business. We want to put some boundaries on business and particularly regulated, licensed business. Doctors are in a business. They provide a service. Same thing with psychologists. They provide a service. And to set certain guidelines or boundaries around what that is, of course, there is some role for government in doing that. Same thing with the guy who fixes your car. Of course, we have some boundaries around that on what kind of damage he can do to your car and get away with it, because you could actually get in an accident and die. So I think we regulate the medical establishment, psychological establishment, just like any other business. This is not a new thing that we're doing. There is no such thing, there's no such thing that the whole role of government and looking at commerce and the way that people interact with each other and exchange money for services or products, the government has always been involved in that. Of course they are, because there is a potential for people to get harmed. And then the government, just like way back Roman Greek times, you have somebody intervene and say, I'm going to try to solve this dispute between the two of you and figure out who is at fault here, who did the thing that was bad. That's the role of government. It's not a new thing to say that
Yeah.
there is some intermediary who is watching that relationship and able to intervene in some way.
Yeah, and I think it's important to realize that there's a historical precedent for large swaths of the medical and mental health profession getting things wrong and having therapies that have previously been endorsed, been researched, been promoted, that eventually were found to be harmful, detrimental to patients, and that when they look back and see how in the world did we promote these things for so long, there was an ideological or a social contagion or a professional pressure component to how they were promoted and how those therapies were implemented. And you can look at the history of frontal lobotomies. You can look at thalidomide treatment. You can look at even the recovered memory and false memory phenomenon that was paired with the satanic panic of the 1980s, where children, under the guidance of legitimate professional counselors and therapists, were found to have these recovered memories of horrific abuse. And you couldn't even speak out against this concept of using these recovered memories without being lumped in with child abusers. And people would accuse you of trying to defend pedophiles or defend child abusers by not believing these stories. And it took a long time to tease out that this was the mental health profession gone wrong, because you could actually implant memories into a child's recollection if you did not conduct your therapeutic sessions in a very specific manner that guarded against that process. So don't think that when they say we can't question the medicine, we have to leave everything up to the doctors, that doesn't mean it's a flawless system. And the process of consistently looking back and saying, are we conducting our profession according to these principles of both medical ethics and evidence-based medicine? Because that system can go awry, and sometimes it takes lawsuits, sometimes it just takes a sobering looking back at what we're doing. And this is happening in America at a time where in Europe, many of the states, specifically states that have state-run medical systems where the government actually is the medical system, has very strong control over both being able to track the data as well as make changes. In some of those states, they've had to reverse course on these very therapies that are implementing hormones and surgery for kids, because as they've taken that sobering look back at what is the actual evidence, are we helping kids in the long term, they've had to confront the fact that a lot of the evidence for this is shaky and not strong enough to justify the irreversible and life-changing effects of these therapies. There are principles of medical ethics that include, first, do no harm. It's tied with autonomy and the principles behind informed consent, where each individual does have the say over their body, and physicians cannot simply impose therapies on people. But that informed consent question becomes very relevant when the types of therapies that are being implemented, if you're not disclosing all of the risks involved, or if you're doing what amounts to experimentation by doing dramatic interventions on people without having strong enough evidence to show that you're solving a problem, that they're going to be better off on the other side of those therapies, then you're betraying some of those concepts of medical ethics. So we'll keep that in mind as we go forward. Okay, so what can you tell me? You met Representative Click. How? Because it comes out in his discussions that he is having discussions in between these hearings with people on both sides of the question. How was he interfacing with y'all at the leading up to this?
Let's see. So he's called me on the phone and talked to me, asked me about my own personal story. So he is talking to people. He is a listener. So what's interesting about Representative Click is he is interested in learning. My background in my master's degree and PhD work is in how the general adults or people in general kind of pursue learning and are curious people and learn in general, and how do they go about that? And how do we increase the curiosity of people? So he's one of those people that kind of naturally has that within him. He is naturally a curious person. He wants to know things and a deeply good person. So he is interested in caring for people, for children in general, and hearing and then absorbing that. And he's not afraid to say, oh, I learned something new actually, so I'm changing my mind, which is nice to hear. I think the other thing about his philosophy that he shared early on with me is I believe he's a pastor of a church, and he sees government and the role of government as outside of that. So he's not interested in integrating kind of church and state in any way. That happens to be his personal foundation, but it doesn't really come into the things that he's doing any more than him as a person. It doesn't really come into the legislative process. So he was very strategic about the way that he thought about this issue with children. He never talked about, certainly not with me. I'm not a believer, never have been. He never talked with me about anything religious or anything like that. And I think that's a common misconception in general around this issue, that somebody is doing this because they want to install some kind of Christian moral authority within government,
Yeah.
which I don't think is true at all.
And this actually comes up where some people say, hey, you're a pastor, and he has to confront that question. But you can also step back and say, is he making arguments from the religious background, or is he making arguments from evidence-based research and the scientific approach to dealing with these complex medical issues? And that comes very
Mm.
clear, where he's not saying the Bible says this or my God tells me this, therefore X, Y, and Z. He's listening to medical professionals. He's listening also to the experience of families who have been through this, to detransitioners who themselves have been through these therapies and stepped away from them. And that's where he's coming from. That'll come clear. Okay, so we've taken some time to dig into the background a little bit with this, and now we're going to take the rest of his testimony and just stop when we need to make any supplemental comments, but see how much we can get through. He started out by laying the groundwork of childhood and the fact that childhood is marked by imagination, by, especially when you get to those adolescent years, trying on different identities, and something that you really feel intensely strong about now may be discarded for something else later. And if you've ever been a teenager or been the parent of a teenager, you should be pretty familiar with this process. And so let's see where he goes from here.
And I'm honored to bring this bill before you today because sometimes adulthood adds a different perspective. When I was asked if I would carry this bill, bills like this were not on my radar when I came to the legislature. I really didn't have an interest in it. When I was approached about this bill, what changed my mind, what motivated me, was sitting in a room with some teary-eyed families who've been through this, who've experienced this. And I spoke to those who asked me to carry the bill. And I said this, I said, if you expect me to throw out red meat, hateful rhetoric, be disrespectful to people, I'm not going to do it because that's not who I am. And they said, that's exactly why we want you to carry this bill, because we don't want that either. This bill is not about hate. You're going to hear some people say that along the way. This bill is about kindness. It's about love. It's about compassion. And we can disagree on certain things. We can disagree on certain approaches, but that doesn't mean that we have to hate each other or be unkind to people. And that's certainly not how I'm going to be. And you have my word on that. And ever since I've introduced it, you have seen that in the way that I have displayed myself and the way I've discussed this bill. But I'm going to ask you if you would give me just a few moments today to explain to you some of the things that have come up in my research as I've explored this bill, as I've read books, as I've listened to podcasts, as I've talked with experts, medical experts. I've talked with people who have experienced this life and lived this life. There's a few things that have stood out to me. Now, first of all,
Okay, so my impression when I heard this opening discussion of the issue and then I heard his line of questioning and all the subsequent witnesses, I was phenomenally impressed. Gary Click did his research. He just talked about doing his research, and it's very clear because he starts citing just off of the back of his hand some things that it's taken me like years to understand. It sounds like he listened to the entire Gender Wider Lens podcast by Sasha Yad and Stella O'Malley. He's listened to the interviews of detransitioners, either on the Benjamin Boyce channel or the other detransitioners that have come out. And he's listened to experts on both sides of the issue, in addition to the families that have come to him. And so this is not somebody who was just handed an issue and then because the party wanted him to do it, he was like, okay, I guess I'll do it. Was that your impression as well?
For sure. He really is super curious. He sent us an email and I say that us as in I'm a co-founder of Partners for Ethical Care. He sent us an email, and I was familiar with him through a parent in Ohio who the meeting that he's talking about where parents came in and talked to him. I know about that meeting, and I know that he's been in contact with so many families. He said, "Do you have more that I can meet with? I need to know more information. I just want as much information as possible so that I can make good decisions around this and understand what's really happening." That's the curiosity that I'm talking about. He doesn't just take something and go, "Ah, I got it. I know what's going on. Don't worry. I'm going to take care of this." He really wants to understand the layers of everything that's happening, how it impacts, like I say, how it impacts the citizenry, the people in his state, and just in general. How does it impact children and their development? How does it impact families? What's happening? Because clearly there is something bad happening that people are coming into his office and crying, and they are greatly impacted. So he wants to figure out what is happening, and then what can our state and me as a representative of my district, what can I do? There's something deeply caring about that. And I will say that I have antenna up for anybody who uses religious arguments, and I am bristle at that quite a lot because I've never been a believer. I don't attend church, never have. And so when people use those arguments, I don't like it. It really grinds me the wrong way. So I find difficulty reorienting representatives and people like that. And he's not like that at all.
Yeah,
He actually kind of does the opposite of that. It's pretty great to work with Gary Click on this.
he also has insight clearly into the fact that this is going to be a contentious issue, and that one of the responses that frequently happens is for you to simply assume that the other person is a hateful bigot, call them that, and then it's the end of the argument. It becomes clear both that he's trying to soften that perspective to get people not to see him or the witnesses that are going to come in support of the bill as hateful bigots, but he's also not trying to paint people who have a different take on this issue as indoctrinated, mindless cult members or anything like that. That's the other side of the coin of what gets taught to them. He sets out saying, I believe, and I genuinely believe that people on both sides of this issue are trying to help kids. It's just that we've got disagreements on what the nature of the problem is, the nature of these therapies are, what the outcomes of these therapies are. And we've got to get all of this information together and try to make sense of it so that we can make the best decision. And he does a really good job of presenting something that is inviting to both sides to come to the table. And that comes clear as you listen to him. So I'm glad to hear that perspective. Now, the other thing is he's a Republican. And the lines in this hearing become pretty drawn around party lines. But if I remember from your testimony, you weren't a red hat wearing Republican. You're not coming to this as that.
I
Is that
voted
correct?
I voted Republican for the first time in my life a few months ago. I have never in my life voted Republican until quite recently. I can't say what that's about necessarily, other than I do vote my values for sure. And I voted in every election since I was allowed at 18 years old. Every single election, even when I lived overseas, I mailed in my ballot. I have never missed an election, ever. So I'm very much an educated voter. I don't do straight ticket things. I actually know about every candidate. You could interview me in the line to cast my vote and ask me why I'm voting for every single candidate, and I can tell you why. So I'm an unusual person in that way. I take voting very seriously. So yes, it's not a partisan issue for sure. We're talking about human beings. And There is something about a lifetime Democratic voter having to say to herself, it's a little bit hard when you have been taught that Republicans are awful, evil, and don't care about you and wish to control you and put us back in the 1940s, let's say. And then you find when you're looking around for somebody who aligns with your values and what you think about something, and then you see all of these people who happen to be Republican, but they're also human beings. And so you say, I want somebody to help me with this. And they say, I'm a Republican. And I say, I don't care. I don't care what you are, actually. I need help with this particular human issue. And I don't think you being Republican changes whether or not you're going to help me with this. That's beside the point. I'm only interested, and this is the funny thing about my life now, I'm only interested in this issue. So I'll work with anybody. I'll talk to anybody about it because every single person underneath all of their labels, descriptors, is a human being. And I'm interested in a human issue.
It's, I don't know what it says, but when you look and you follow these hearings, it becomes very clear that when you look up at the representatives on the other side of the table, their opinion and perspectives on this issue is drawn right down party lines. But when you look at the witnesses and the families that are giving testimony in concern over this issue, it totally crosses party lines. And people make a point of saying that. It's not because I'm Republican, it's not because I'm religious. This is just an issue that has affected me, that has affected my family, and it's something that we need to take very careful look at. I don't know if you were to ask the people who were testifying critical of this bill and in support of the therapies, there still may be a political dimension there where they would all be Democrat or be on that side, but they don't really talk so much about their political plurality when they give testimony.
People want to be part of a group. This is true in the issue of gender. People like to be part of a group and they like to have group affiliation. It gives them some sense of stability. I think that somebody's going to welcome them into something or have their back, I would say. So we all want to feel like we're part of a group in some way. So I can understand, particularly people in government, want that as a fallback kind of idea that, hey, I'm part of this party and they're going to support me on things. I think in the national landscape, we see when somebody does something that their party doesn't like, they get a slap and a push and it's pretty hard to get out of the party. Your podcast talks about kind of group affiliation and how that plays into your individuality and all that stuff.
yeah.
I don't think this is different. I think that in a what I consider a crisis where we're talking about children's development and life possibilities, as you say, psychologically and physically, you stop thinking about group affiliation and you really narrow down on your specific child, what is best for your child. And then you will start to try to figure out anything in order to help your child because it impacts you as an individual. It didn't impact you because you were Republican. It didn't impact you because you're white. It just is happening right now. And you'll really take anybody to help you. And I usually say something like, I'm not afraid of right-wing cooties because that's not real, right? You
Yeah.
only think that there's something that makes people who have signed some sort of form that says they're Republican, we think that makes them a bad person or a good person. Certainly that's not true.
And when you have people who have negative consequences if they step out of line with what is they understand the party line to be, intersecting with whether or not we can put up safeguards around these therapies and around how the medical profession may be failing patients, where you see that can have real consequences. So if you ever do find someone who steps away from party lines to do something, and pay attention there, because there may be something significant going on for someone to take that level of risk. But I don't know that we're going to see that in these hearings. So let's continue.
You're going to hear words like trans, transgender, trans man, trans woman. The clinical term is gender dysphoria. And gender dysphoria is real. People experience that. And people experiencing gender dysphoria deserve to be treated with all of the same love, respect, kindness, and compassion as anyone else would. Gender dysphoria is an extreme discomfort with one sex. Sometimes it is associated with a strong desire to be the opposite sex. Sometimes it's not. And you've probably heard the term non-binary, or sometimes they just use the abbreviation NBs for non-binary. They don't want to be the opposite sex. They just don't want to identify with any sex. But what surprises me the most and what troubles me the most is when there is a lack of professional curiosity that goes along with this. The professionals are not all in agreement on this. You're going to hear some testimony from the other side, and I look forward to that. But they're going to say, clinicians say this, and professionals, why don't we listen to the professionals? I've done a lot of research, and there are a lot of professionals who have differing opinions from those that are standardly publicized in the press, in the media, and on their own websites. Clinicians are not in agreement. But in contrast, there's an increasing social pressure to simply accept that some people are trans and to say this is what it is, and there's no reason. It was just somebody made a mistake. They put a boy's spirit in a girl body, or a girl spirit in a girl body. You've heard the phrase, a girl's brain in a boy's body and a boy's brain in a girl's body, and things like that. That's just not scientifically accurate. And so we want to do, when we're talking about delving into medical interventions, we want to be careful. We want to make sure that we have the science on our side, not just a philosophy, not just an idea, not just a strong belief, but this has to be filled with science. And that's what we're here to stand up for today, because there are people on the opposite side of this issue who only want one answer. The only answer is gender affirmation. And they will say things like, if you're not performing gender affirmation, if you do not affirm the child, then that must be some sort of a conversion therapy or something like that. And neither is that true, and neither is that the recommended process that we should take from that. So one of the factors is that there's actually a lot of significant pushback on this, even within the LGBT community. There are many people in the LGBT community and even in the trans community. So Trey Voices is an example of one group that is in the trans community that says, listen, we're happy with our transition, but transitioning is hard. It's a very difficult choice. It has lifetime consequences, a lot of expense, and a person ought to be grown, mature, and ready to give informed consent before they pursue this pathway. So this isn't just one side of the aisle. It's not just one ideology that we're presenting here or one position. In fact, as I began to study this, I learned that there are both Republicans and Democrats who take our position, as I said, and also people within the LGBT community. So there's really a diverse number of people from a diverse number of walks in life who say, let's just take our time. We're not saying what the end decision should be. We're not saying what decisions you should make as an adult. We're not making any moral judgments on anyone. But what we are saying is there is a time and a place where we make these life-altering choices.
Okay. So he covered 2 points there that are worth reflecting on. The first thing is there's this idea that the science is settled. Everybody knows that this is affirmation therapy is the only way to go, and it produces the best results, and kids will kill themselves if you don't do that. Those are all assumptions that exist out there that make their way into how the medical profession responds when you send a child to a gender clinic. And what he's trying to point out is that those assumptions are not backed by the evidence and the data. And you may feel even that because there are professional societies that endorse that perspective, it must be scientifically sound, because there is an international body, WPATH, that endorses these therapies, that it must be backed by the evidence. But when you go back and ask the question, is it backed by the evidence, and how strong is the evidence, and you dig into the studies, it becomes very clear that the evidence is not as strong as what we would hope to see when we're making these irreversible changes. And there's a big blind spot, which is these detransitioners, and the reality that if you start out by saying this is a trans child, and then you do all of those hormonal and surgical therapies, if they later detransition, what do you do about that? Because it means that you incorrectly identified someone as a trans child and took them down a route that sterilized them, that made irreversible changes to their body. And you did that as a harm to this patient who it turns out is not trans. As we see here in the States, that is probably going to have medical legal consequences in the future in the form of malpractice litigation. It hasn't hit yet, as we anticipate it's going to blow up. But those are the real issues here. You cannot say the science is settled. You cannot say that there is universal agreement among therapists. And you cannot say that the evidence is incontrovertible. And that's going to come out, I think, as we see these. Anything other else to add?
Yeah, let's say we do assume that there's such a thing as a transgender person and detransitioners were never trans in the first place. We've harmed them to a point that we have very likely shortened their life. We've made their quality of life not great at all. They have real physical problems and obviously psychological distortion that they probably didn't have as strongly as before, or that they may have grown out of, but has now become permanent. Very much like it reminds me of the temporary order in my case that then became permanent because over time, the more my daughter was separated from me, the less she wanted to see me, actually, because we didn't have any connection to each other. It became more and more distant in the same way that if you continue to change your own body to the point as a woman injecting testosterone that you're starting to grow facial hair, you're starting to become more distant to the person that you would have been actually very close to and become comfortable with after a little while.
Helen Joyce has a book called Trans When Ideology Meets Reality, and she maps out the evolution of studies that have been done in this area. And she points out that the watchful waiting paradigm, which has historically been how you deal with children that experience gender dysphoria, if you don't socially transition them, don't give them puberty blockers, don't give them any cross sex hormones or surgery, but just give them supportive conversational psychotherapy, then by the time they reach adulthood, a
Mhm.
majority of them, and people can argue whether it's over a small majority or a large majority, but people agree it's a majority of them will desist. That gender dysphoria will resolve, they'll integrate with their biological sex and continue to live their life having integrated that component of who they are and deal with all of the other challenges that life has in store. But when you do the social affirmation, when you do the cross sex hormones, that is an intervention that changes from a majority of people desisting to an overwhelming majority of people persisting in that dysphoria. And so that intervention is keeping people in a state of gender dysphoria that then is tied to a cascade of therapies, each of which has their own risk factors, complications, and marry that to all of the heavy burden of psychological difficulties that go along with trying to live as a transgender individual. It's a very significant intervention that they're doing in the lives of kids that will affect them for the rest of their lives.
Yeah. I want to comment a minute on the concept of watchful waiting that used to be something that actually was in existence. Watchful waiting would be the natural idea that the child is existing in his social cultural context and simply impacting and being impacted by the world generally. So what's happening now is there's a cultural moment in in which society is actually producing positive reinforcement for certain behaviors, and they're pushed by actual regulations within their schools or guidelines in order to enact positive reinforcement or the affirmation model. So the concept that we could somehow go back to watchful waiting, I don't think is possible because the positive reinforcement that exists in society doesn't allow for waiting. It's an actual psychological intervention that everybody, via their professional standards or their rules at their workplace, are forced to participate in a positive affirmation, positive reinforcement model. So we can't watchfully wait anymore and think that a child is going to desist from their identity through a natural integration. It's very unlikely that's going to happen within the social, cultural, and time bound context that we're in right now. So the data, even that we have on watchful waiting, I'm not sure that it can be applied now because of where we're living in this moment. And that's really unfortunate that individuals, adults, have been incentivized or basically negative consequences happen for reinforcement if they do not comply with the positive reinforcement affirmation model.
So, the other dimension that Representative Click talked about here was that this is not a partisan issue as it exists in the lives of people. It unfortunately may be partisan politically on this by what perspective each party holds on it, but in the lives of the people that it's having. And he brings up that there are even trans people who don't agree with the way that medical and surgical interventions on children with gender dysphoria is happening. And that there are people within the LGBT community more broadly that have a lot to say about this issue and don't agree with the way things are going. Anything to add about that?
Yeah, he refers to Trey Voices, which is run by Scott or Kelly Nugent. Scott, this is the reality of her biological sex. She's had a number of surgeries and interventions on her body. And of course, psychologically, that does its own kind of toll. So I think she's come to the realization that no one goes backwards. We all move forward. It's just a matter of in which direction. Of course, Scott is mostly perceived as a biological man, probably. So I think Scott is just coming to terms, obviously, not just as in recently, but is simply coming to terms with the reality of her life and her body and how people perceive her. And there's a certain kind of peace that comes with that to just say, I understand that people perceive me this way. I know who I am, and I'm okay with what others think about me in some way. It's complicated to exist in a world like that, but there is some peace within yourself that you can gain from that by saying, I understand that I did make choices as an adult around this, and I am facing the consequences of that. As a parent, as a mom, she has children, and it's complicated to have interactions with people so close to you and have all kinds of health problems and wonder how long your life is going to continue in number of years and what the quality of that life is going to be. But the idea I think she's expressed is there isn't any going backwards in time. And even if I wanted to intervene in a different way, the trauma of a number of surgeries makes it unlikely that she would want to do more. Of course, not knowing the outcome because we're talking about experimental medicine. So I can understand and have compassion for what's happening to her in her own mind and the point that she's come to in terms of accepting the reality that is true for her at this moment today. We would hope, and I think she hopes, that other children can come to accept the reality that is true for them today, even if they're 8, 10, 12 years old, or if they have had a double mastectomy or had a vaginoplasty or something like that, that they come to terms with the reality and aren't trying to then be in a constant state of pushing out this idea that they are somehow the opposite sex. So I think I admire Scott in that way for coming to terms and being somewhat at peace, as I can see, about the reality of her body and her life. And of course, it's sad what you said, and I think what my father said, and I'll talk about that later, is we are talking about a shortening of somebody's life, and their quality of life certainly is diminished.
For people who aren't familiar with Scott Nugent, you'll see him as one of the people Matt Walsh interviewed in the What is a Woman documentary, and specifically a trans person who is speaking about the differences between the way the modern discourse on trans individuals is compared to the past, and also the serious complications that may arise or uncertainty involved with the surgery. And there's this dramatic moment where she reveals the donor side of the skin that was used as part of the sex reassignment surgery. And in addition to the hormonal issues that we're seeing here, I think there's going to be a reckoning in the future of the high rates of complications of the various sex reassignment surgeries and whether or not they can be ethically continued in view of those complication rates. But that's to be determined in the future.
I want to comment for just a minute on the word transgender. I think you had talked about it before as what does this word mean and how is it used in context? Do we have children who are trans? And then, of course, that would mean that we have adults who are trans and that there is such a thing as a transgender child or a transgender person. And is that an inherent kind of quality, or does the identity kind of change over time? As in, today I'm an engineer and tomorrow I'm a country music star. So I agree that we need some descriptor for a person who has had such extreme body modifications as cross-sex hormones and surgeries. I'm going to say that that community needs some sort of word to describe themselves, just like anybody, maybe cancer survivor as an example, or victim of domestic violence. There's a way in which a moniker like that kind of can solidify an identity that may be good at times and may also be bad, that we then find ourselves in a place where we have to then reinforce how much of a country music singer we are by constantly performing at parties. That I just can't exist in a space, and then I leave that place and somebody says, "Oh, that Jeanette, she seemed really nice. She never said what she did. Oh, she's a country music singer. Oh my gosh." And it never crosses their mind because it's not a thing that I'm constantly pushing out. I'm just existing as a multifaceted human being who just happens to be a country music singer, or that is something that may change over time. But I don't know if I can agree that the descriptor of transgender person is something that wouldn't change over time, or that the person themselves would say that. I think this is also true of my own daughter, I'm a white lady, and her dad is Indian, as in from India. So I, of course, have watched her over time, and with many biracial, multiracial children, multi ethnicity children, describe themselves in various ways. Sometimes she'll go, "Oh, I'm American. What are you talking about?" Or, "No, I'm Indian." And of course it's that way. That changes over time. That's a reality. It depends how she's using it and why she's using it, and what is the thing that you're gaining or adding insight to when you speak from that position of that descriptor of identity. I am cautious to use the word transgender to describe somebody in a very finite, unchangeable way. I am hesitant to do that because it is not necessarily always be true in a way that the person themselves would describe themselves. So I'm hesitant to agree with that.
That makes sense. The way I've tried to frame it in the past or think about it is you hear people say trans kids, and and it's almost like if you were to hear somebody say, that's a Baptist kid. Let's hold on a second. How do you know that's a Baptist kid?
Yeah.
Because, they're going to have a life full of different experiences, different ways of thinking. And it may turn out that they don't. Baptist is not a label that you give a kid and cement their identity. And now they're in a prison of that identity for the rest of their life. There's no Baptist gene or Baptist organ in the brain. There are adults who are Baptists, and absolutely they are Baptists, but that is an identity, a community, a theology. It's all of these different things. Just being trans is a way of thinking about themselves and a way of thinking about the world that an adult may say, I'm trans, but you cannot take two adults who say that they're trans and assume that they both frame that idea in the same way, because you can find people who believe that they're trans from the queer theory perspective, where gender is performative and they're inhabiting a gender that is marked by the outward appearance. And then you can find trans people who don't accept the performative gender philosophy about trans, but just simply choose to live life in the opposite gender, even though they know that their biological reality is different from that. And there's different ways that people who hold each of those different ideas may think that society must or need not conform to their way of thinking, but it's an idea, it's a philosophy, it's a belief about these things. And you can't take those labels, slap them on a kid, and then assume that you know what that kid is going to be. Or what may be happening is when you put that label on the kid, it now confines the kid into what choices that they may have as they go through the tumultuous years of adolescence. And that's why therapists should, from an ethical perspective, not be getting kids to cement a particular idea in these kids going through puberty, because that whole process of maturing from a child into an adult involves trying on different identities and then integrating who you are as a person at the end of that. And I very much agree with your idea of being very careful how you use these labels, particularly avoiding slapping them on kids. Now, if you say this is a child who's experiencing gender dysphoria, it doesn't define the child. It describes an experience of the child that may have a certain cause, may have a period of time that they're afflicted by it, and may have a resolution or a persistence that is determined in some way by how you respond to it.
Yeah, and that's what Gary Click is talking about in that piece of testimony that we watched, is that gender dysphoria is a psychological kind of condition, of course, that may change over time. And so recognizing that it could change over time inherently means that it does not equal a trans kid that is somehow solid. Those things cannot be equated.
All right, well, let's keep going to his next segment.
We look at causality, and I think I already addressed that a little bit. I got a little bit ahead of myself. And we really don't know what the cause is, but we do know many times there are multiple causes. But to say that someone is just born that way, there's no scientific evidence that demonstrates that. Neurologists have studied this, others have studied this. There is no known one specific cause, but there are factors that influence this. We also want to point out, as we talk about this, we're going to get into comorbidities in just a moment, but PSD, that's a disorder of sex development. That is completely distinct. I know some people have confused that, and some people have asked me how that applies in here. That is not a part of the spill. That is an indication when someone has an extra chromosome instead of X or XY, they might be XY or something along those sorts. And then there are other types that have to do with virilization. People with intersex condition or DSDs are not affected by this spill.
Okay.
I just want to talk about how Gary Click knows so much about this issue that I wish I could download into the brains of thousands of people that I talk to. How in the world did he become so well versed in things that for sure it takes people years to say, what's intersex again? And watch copious amounts of videos and read articles and all of this. And he distills it down into 3-4 sentences. It's amazing. It's amazing. I wish everybody could have that understanding so quickly.
Yeah. And he's also looking ahead of the game. He knows the responses that are going to come because you can draw the lines because we're going to make this argument. People are going to say, you're arguing that trans is not real and that biological sex is binary. Guess what? There are intersex individuals who show you that sex is not binary. And he's just trying to cut that argument off because you could spend days on that argument and try to get biologists, everybody. Regardless of that, people who are being affected by this and the percent of intersex individuals who maybe have a malformation of genital formation based on chromosomal or other developmental abnormalities that are going to be affected by this bill is almost non-existent. This is because of the overwhelming majority, almost totality of the people affected by this bill are not intersex. And so bringing that argument about the binary or binodal nature of sexual biology is completely irrelevant because the doctors involved in this are not looking at sexual biology. They're looking at self-identification of gender and then immediately affirming and running into a whole bunch of surgical and hormonal therapies.
Yeah, they're looking at something that isn't measurable via some sort of blood test, biological test. They're looking at something psychological.
Okay, excellent points. Let's keep going with Representative Click.
Do know is that most people who experience gender dysphoria have comorbidities, even up to 4 comorbidities. In other words, there's other things that are going on in their life. What are some of those other things? They include anxiety, depression, suicidal ideations. Autism is very high on the scale for people with gender dysphoria, schizophrenia, low self-esteem, bullying, and more. There are also some cases and some concerns about FDIA, which is fictitious disorder in another. And that's more commonly known or recognized as Munchausen syndrome by proxy. The name has changed. What we find is there are some cases, and there are reportedly some cases, and I've documented them, they're in your footnotes, where this is imposed on a child by their mother. In fact, there's one mother who has given a TED Talk. Her name is Amber Bingle. And in her TED Talk, she has a trans child, she says, who's about 5 or 6, at least at the time of the video. And she says, my daughter told me she was a boy from the womb.
Now, before you say that this is just a phase, may I remind you that this perfect human being has told me from the age of 2, y'all, from within the womb, he told me he was a boy. The day after Halloween, my child stopped being a ninja zombie, but he did not stop being a boy. This is not a phase. This is his real life, and we will honor that.
And so it's not a surprise when a mother might say that ultimately that child might identify that way. And you have to suspect that the mother's influence may have had something to do with that. Some other things that take place, and probably one of the most heartbreaking contributing factors is sexual abuse. There are many people that I have talked to personally who have experienced gender dysphoria, and it began because someone abused them. And that sexual abuse becomes something that needs to be dealt with, needs to be explored. I think it breaks every one of our hearts. We're not saying this is the case for everyone, but we're saying that this is the case. But when the only care or the primary care that you give to someone is to affirm the dysphoria, to affirm, say, yes, you are, and you don't explore that, you're not doing a service to the child. You're not helping that child because that child is not able sometimes to even express the trauma that they have experienced. And what do? We just complicate it by covering over it and giving an escape out of that trauma. And many times they think if I was a girl, maybe this wouldn't have happened to me. Or if I was a boy, this would not have happened to me. And we can talk to you about Walt Heyer. Walt Heyer is one of the oldest probably living people. He was one of the early pioneers to go through this. And his experience began because his grandmother started dressing him in a purple chiffon dress when she was babysitting him. And the parents didn't know this initially. And after doing that, his uncle molested him. And that molestation caused other psychiatric disorders. But he thought he was transgender. And so he went and he ultimately transitioned. He lived as a woman named Laura for 8 years. And he realized this was not alleviating his anxiety or his depression. He actually went to school at, I think, UCLA, studied psychology and psychiatry and so forth. And he realized, I don't have gender dysphoria, I'm schizophrenic. And it's a real story. And he ultimately detransitioned. And he has a webpage that is entitled sexchangeregret.com, where many people, hundreds and hundreds of people, reach out to him and tell him, I wish somebody would have done more research. I wish they would have explored more. I wish they would have really found out what was causing my gender dysphoria instead of just instantly affirming me. And that there's story after story about that. But gender affirmation therapy is a type of therapy that is supported by intimidation, fear, manipulation, and isolation.
So this concept of comorbidities becomes one of the most important observations that you can make, because whatever gender clinics you approach worldwide and ask them, like, how has your population changed of people seeking services for you over the past decade or so? They'll say we've had an explosion of new people seeking services because of the experience of gender dysphoria. And then they'll also say it's disproportionately young women, teenage girls, college girls. And historically, when a lot of this research was done, it was not that population. And even if you look at the research that was done, which established these protocols, it's something that was published. It's called the Dutch study or the Dutch protocol. And it's the primary study cited by WPATH that's then carried over as a recommendation into the Endocrine Society and the Pediatric Society to justify these therapies. When they designed that study, they specifically excluded anyone who had any of the comorbidities that Representative Click is talking about here. If you had anorexia, if you had depression, anxiety, all of these other comorbid things, you would be excluded from that study and you would not go on to that. So then the conclusion at the end of that study saying that they had a positive result, even without looking at the legitimacy of some other aspects of the study, you would say, okay, this would be a positive result, but you could only apply it to patients who had none of those comorbidities. But when you look at the surge of young women in particular who are presenting to these clinics, and majority of them have not just one, but multiple comorbidities that if you don't explore, then you're taking them down a route of therapy that you can really have no confidence that you're addressing the actual issue here. And there's Swedish documentaries that I've recently posted on the channel. The second episode in particular does a great job of exploring this question of comorbidities and then takes you along the life of an individual who experienced body dysmorphia and anorexia, and then came to believe when they were exposed to the issue of transness and the ideas of gender, believed that they were actually trans. And it was that transness that caused their anorexia, and immediately started to go down that line of therapy. But because there was a big waiting list to get into the clinic in Sweden, in the meantime, she got a therapist, and the therapist didn't do the affirmation only model, but instead did the exploratory conversational psychotherapy and said, let's, tell me about what does this mean to you? And then explored her psychological background and allowed the patient to consider other perspectives. And it ultimately ended up in her removing herself from the pathway of hormones and surgery and starting to integrate who they were in dealing with those underlying psychological issues.
So I happen to be taking, I'm in a PhD program in education, but I happen to be taking a class just because I want to, and I'm a curious person, a class called Treatment Methods for Children and Adolescents. And it's really around treating disorders. I'm getting about halfway through that class. And it's a graduate level class for people who are going to be clinical psychologists. So it's part of their required courses. And we know that generally children do not have kind of one thing going on. They don't just have ADHD, generally speaking. They usually have two, three, four things going on. And to say that even a clinical psychologist would not say that some one thing may be presenting as primary, but there are other things. And so the clinical psychologist, I'm learning, makes a decision about what should they address first and what kind of therapeutic intervention should they take. In the gender dysphoria realm, we see that gender dysphoria and its presence trumps every other intervention in a way that doesn't make sense. So to say that gender dysphoria is the thing that needs to be addressed immediately and to the point that the other comorbidities are actually not addressed at all, or in the worst way, are somehow those things are caused by the gender dysphoria. The reason that I have depression is because of gender dysphoria. The reason that I'm anxious is because of gender dysphoria. There's something a bit, I don't know that evidence would hold for those things. What's interesting is when you were talking earlier, a couple of minutes ago, I thought about trauma. You used this word integration, and I've recently been reading more about that concept. We know that in the cases of trauma, that the vast majority of people will integrate the trauma that they experience, that acute trauma or even episodic trauma of their childhood, they will integrate that into their life story in the same way that it's possible for somebody to integrate the discomfort with the reality of their biological sex into their life story. Oh, yeah, I remember. I totally felt like I was a boy. And now I look back and I can understand that, or I don't understand that. But it was just like a period of my life where I dressed that way and I asked people to call me a name. And now that was just second grade or whatever it is. They integrate that period, whether it's a traumatic event, into their life story. That's a thing that happened and that I experienced in my life. And it's part of my narrative. Or some people, it doesn't, they have trauma and it carries on with them, and we don't know why it doesn't get integrated into their life story and they actually need intervention. Trauma that is unaddressed is not necessarily something that carries on in the same way that gender dysphoria, unaddressed, does not carry on. So there is a pseudo watchful waiting method for trauma that exists mostly because people cannot get treatment for trauma. The situations that they're experiencing have a lot to do with poverty, and they just don't have that accessibility to mental health services. And so they figure out in the social and cultural sphere of their lives how to make meaning of that as part of their life narrative. So I only say that because we know, just statistically speaking, that the people who are experiencing or being diagnosed with gender dysphoria are middle upper class white children. And the people who are experiencing the vast majority of trauma, for example, are lower class non white children. So the ability for us to gain access to mental health services that then shine a spotlight on something like gender dysphoria and maybe bring it to a pedestal where we kind of navel gaze at it, or we look at the gender dysphoria in great detail to where it becomes that we're continuously refocusing ourselves on and refocusing ourselves on it, that we're constantly bringing it to the forefront, is not something that's possible in many ways in low income, non white communities. They simply don't have the resources and they have to use other methods to integrate or to make meaning of the things that happen to them. And trauma is an example there's something good, and that I think clinical psychologists and all kinds of people in the psychological field would say that integration is what you want. You want the bad experiences of your life, the discomforts of your life to be integrated into a larger narrative of your life. You don't want it to overtake your entire life story. And sometimes looking at it and refocusing on it every week, or putting it in some sort of descriptor in your bio as I'm trans, might make it more likely that kind of thing is not integrated.
Yeah. And there can be different perspectives in how you pursue therapy that can lead to different results in that regard. One of the things that is pointed out is that this mindset that our younger generation and the institutions that are stewardshiping them through adulthood, like our schools and our institutions, have adopted this perspective that's from a source of compassion, but ends up framing children's experiences and individuals' experiences as victimhood. Then, if the therapy perspective is let's explore how you are a victim of society and microaggressions and all these different things, and is focused on reinforcing your identity or your experience from that victimhood narrative to these wider cultural forces, then that's going to tend to cause that rumination and looking for and finding little examples of oppression or victimization in your daily interactions. But that's a very different perspective from what cognitive behavioral therapy is centered on, which is taking some of those distortions, not seeing yourself as a victim, but finding a way to minimize some of those circuits that would tend to catastrophize or to do mind reading or any number of the things that are involved in finding yourself as a victim in any circumstance, minimizing those and coming up with healthier ways of framing your experience as you live the world, healthier than seeing yourself only as a victim of these outside forces. So those different approaches to therapy can lead to very different results. And that's where, even when you hear in these arguments, people will say it's not really quick. When they go to the gender clinic, they're being seen for multiple sessions over multiple months before they ever get any hormones. And you'll have witnesses that say, actually, it was after just one session or just a handful of sessions, and then I got my puberty blockers. But let's say that's not the case and that it is multiple sessions of therapy. If all of that therapy is centered around, okay, how can we shape your family's life? How can we shape everything else around your gender identity in that affirmative mode? That's a very different aspect of therapy from the conversational cognitive behavioral therapy or exploratory psychotherapy, which would say, let's look at the complex landscape of all the different challenges in your life in many different domains and see how they may be playing a role in this gender thing, or how those issues should be addressed first before we even get to progressing down the pathway of intervention on transition. And so simply saying that people are going through therapy doesn't necessarily mean that it's the same thing. And that can't be lost as we approach listening to the questions and witnesses here. One of the things that he explains is that in addition to autism, depression, anxiety, sexual abuse tends to show up in the stories of these kids and young adults, particularly when you listen to detransitioners who are finally able to confront that aspect of their history and frame their experience with that dimension. If you are only doing the gender affirmation only and you're prevented from exploring those other things, then you're leaving significant psychological trauma unresolved. And so you could ask yourself, how is it these clinicians are doing that? And the stories that you're hearing from the family's patients is that when the patient says, I have gender dysphoria, I'm really trans, the non-gender clinic therapists are telling the parents, well, I want to explore these other things, but I'm afraid that my license will be in jeopardy because that would be considered conversion therapy. Because I'm looking for some other explanation for why the child is declaring themselves to be trans. And by looking for those other explanations, I'm inserting a presumption that they're not really trans and that we need to look at these other things. And if we can address these other things, then I'll convert them to not being trans. And Click is so prescient in his presentation here. He started out by saying that they're going to call some of this stuff conversion therapy, and that's just not what it is. And that distinction is really important because I think the layperson first introduced to this idea will hear, oh, some of these hateful, bigoted therapists are trying conversion therapy just like they did to the gays. And they'll assume that it's the type of conversion therapy that is another stain on the history of mental health professionals, where use electroshock therapy or other means tried to convert people from having same-sex attraction. And it's just not the case. We're talking about something very different in terms of gender identity as it's being framed now in compared to who somebody is sexually attracted to as an individual.
Yeah, it is. You're talking about that identity piece, that it never changes and that you are born that way, which is different. And this is the tension that we're watching play out right now in general in this cultural moment that we're living. The idea that somebody is trans and that somehow if we talk to them about something and then they say, "Oh, actually, I'm not trans," that we have somehow stifled, suffocated their true identity, and that they will be in a constant state of suffering or confusion, that they were born trans and now they've got to hide that. Maybe in the same way that some people would say, "No, I really have always been gay, but I don't practice it," or whatever they say in terms of same-sex attraction. I don't know what the idea is behind that. But like I said in my own testimony, we'll get to this, is nobody's performing surgeries on gay people, and certainly not children who say that they're gay. We're just not talking about the same thing at all. The idea of conversion therapy, for sure, we're watching go through legislators, but it is around this distinction that I don't think is quite clear in our society, which is gender dysphoria as a psychological disorder or condition that somehow I think that I am not at peace with the reality of my biological sex. And then there is this thing called trans, which I absolutely would consider sand in the hands. There is no definition that society, I'm not sure, will ever agree on that is trans.
With those distinctions made, but so he does bring up this story of Munchausen by proxy, which is where a parent has some incentive, some need, some reason to impose a disease on a child that gives them some benefit or attention, some
Mhm.
psychological fulfillment that is itself a disorder. But it's a
Yeah.
disorder not in the child, but in the parent. Nevertheless, the child experiences negative consequences from that. What's your understanding about the story he brings up?
So if we know that parents influence children, that's true. We know that parents who have suffered some sort of abuse or neglect in their own childhood then impact their children in ways because they have learned to cope with that abuse, neglect, whatever environmental situation and traumas that they experienced as a child, then, of course, become part of how they act and behave in the world. That then, of course, impact their child because they've developed certain coping mechanisms around that then could positively or negatively be taught to explicitly or learned by a child. But we know that parents influence the lives of their children because parents are the greatest piece of a child's environment. The thing that he's talking about, this Munchausen by proxy, it's not the parents who are suffering from this kind of psychological psychiatric disorder. I don't know which it is. They're suffering. They don't know that they're harming their child, actually. I have compassion for people who are suffering from this. The problem is they're harming other people, including children. That's the issue. And there has to be some sort of prevention strategy because the person who is suffering from this is, my understanding, unaware that they're harming their child. They actually think they're helping them. And you want to prevent that harm to children in that way. So Amber Briggle describes it in her TED Talk that Click said she believed this child to be born in the wrong body in utero before the child was even born, which I'm not sure how that even happens. I was at a rally December 1st. There was an abortion decision. I was at the Supreme Court in Washington, D.C. last year, 2021. And there were people chanting trans rights begin at conception, which is an interesting concept.
But
I'm not
you could imagine how her statement that she knew her child was trans from in the womb, as outsiders to the ideology will say that statement cannot be backed in any way by any evidence. And so it clearly points to strong beliefs on the part of the parent that may be affecting how the child is developing. But from inside the ideology, you could say, yes, this idea completely supports what we want to have, which is that a trans individual is an entity that is a born this way entity that then we can only see any therapy that would tend to change somebody's perspective from identifying that way as a conversion therapy that is, you could frame it as a genocide of trans people because it's getting people not to confront their lived reality. And so it really changes based on your perspective how you see that issue. Because you would almost say, why would she want to admit this in public? Because it exposes it as an unscientific, faith-based idea.
But she doesn't understand that, right? She's suffering from a psychological disorder, so she's not aware, just like a narcissist is not aware they're a narcissist or they have that psychological disorder. If you have it, it inherently means that you're not able to identify that you have it. If you could, then you wouldn't be suffering from it. You would be able to metacognition, look at your own thoughts.
9-year-old Kieran Clausen collects crystals. She dabbles in face paint and she loves sports.
What do you play?
I did play volleyball, soccer, and I want to play basketball.
To Kieran, who's transgender, it's not about racking up victories.
I don't want to win any trophies for it, though. I feel like that's the most unfair way to compete because it's not about winning.
What's it about?
Having fun with your friends for it, though. I feel like that's the most unfair way to compete because it's not about winning.
Kieran seems undeterred with a message now about her journey.
Never stop being you. That's it.
Never stop being you.
There's so many kids that don't even have the opportunity to express who they really are. We are acknowledging more people as who they are than taking something away from somebody else.
The Munchausen by proxy phenomenon that Click describes here is complicated by something that was first brought to my attention by Exulancic, what she calls the clever Hans effect. And you can wonder if this issue is in the parents and they're somehow bringing this idea that the kid has this disorder because it fulfills some psychological need on the part of the parent that they may even not have any insight into. Why is the kid participating? How is the kid participating? Because we see this kid and they claim that they have the gender dysphoria. And she points out examples where the parent asks a question of the kid and the kid gives a response that maybe isn't in line with what the parent expects and wants to see from the kid. And so the parent either withholds or gives disapproval. And so the kid gives another answer, not exactly what the parent wants. And so the parent does not approve. And then the kid gives another answer, anticipating what they believe the parent wants. And then the parent says, yes, that's right. And so take a single incident of that may be captured on camera, but then realize it's happening throughout this kid's life. And it's teaching the child how their environment will give them positive reinforcement for responding.
And then one day I just randomly asked him if he felt like a boy or girl, both or neither. And then it became a question that he looked forward to me asking every morning. So at first we were like, okay, maybe just gender fluid.
So the parent prompted and cued the child into answering a question about what they identify as, and then presumably got excited at the answer. And probably got more excited when the answer changed, which taught the child that the answer should change. That's the right answer. It's just new answer every time. And through this interactive process, the parent conditioned the child in a form of the clever Hans effect that I've called the clever Hansel effect to refer to children when it's happening between the parent and the child. It refers back to the clever Hans, which is a horse who was inadvertently trained to pretend to count. And so this parent is conditioning and coaching the child into giving unusual answers for their gender responses. And then also likely, as I showed earlier in the video, conditioning the child towards saying that the child identifies more as a boy. Because clearly that's what the parent wants to project onto the child. That's what would validate the parent's religious beliefs.
And then for about like almost a month and a half straight, every single day, he said he was a boy. And it's just kind of landed on that.
I kept asking her. And when she would experiment with different answers and she would say boy, mom would get really excited. And that taught this very young child that boy was the right answer. And she kept doing it. She kept coaching her until she consistently gave her that answer for a month.
So now he wears boxers by choice, and he feels much more comfortable and like himself.
We know that this child is being extensively coached, whether they mean to or not. That is what they're doing. So it's very, very easy to coach a child and say, "Oh, do you like these? Yeah. Oh, well, is it because they make you feel more like you?" And you just get them to repeat that, and you just keep practicing it. And then you go on Rosie O'Donnell and say, "Oh, well, she came to me. She came to me and said she wanted to wear the boxers." And that was true 3 weeks in.
And wearing what are typically considered like boy clothes, but we've kind of broken down the gender construct around those clothes themselves. And there's still days where dresses are the norm.
She's not old enough to have formed a construct to be breaking down yet.
Do you think that your transition has affected Tase's situation with gender?
Yeah, I definitely think in some aspect my transition has had an influence. It'd kind of be hard for it not to, but I have not projected any of my experience onto Hazel.
Disagree.
What I have done is provided a healthy example of, essentially a role model.
QED.
Once you see that in action, you can start to understand how a parent with a strong belief about what their child is experiencing can shape how the child responds to people outside of that parental environment. And seeing that clever Hans effect, and she explains that it's related to a horse named Hans, that it looked like they were responding correctly to questions by doing hoof stomps, but what would happen is that they would stomp their hoof until the person asking the question would respond in a positive way, and then the horse would know to stop because that was the answer that was expected.
Pavlov and Thorndike argued that animals that appear to think are usually only responding to reward or punishment. This was the case with clever Hans, a horse with the amazing ability to tap out answers to math problems. But it turns out Hans wasn't especially good at math, but at reading his unwitting trainer's subtle, nonverbal cues for when to stop tapping.
It looked like an authentic response from the horse Hans.
Do you feel more like a girl or like a boy?
A girl.
Why do you say that?
Because I'm a girl boy.
Is that why you chose this beautiful outfit
Yeah.
for cheerleading today?
Mm-hmm.
Yeah. So you feel more like a girl.
Mm-hmm.
What do you think about boys?
Nancy.
Why?
Because they're girls.
They're. Why do you think that? Why do you say that?
Because they're not pretty.
They're not pretty?
Mm-hmm.
Why aren't they pretty? They don't. Is that because they don't wear pretty outfits like the one you're wearing?
Yeah.
Okay, that makes sense.
Tasteful.
Jojo?
Mm-hmm.
What about Jojo?
I like her. No, I Jojo's mom.
You like Jojo's mom? You know mommy loves you, right? You know mommy's gonna be proud of you forever, right? I'm so proud of you. It is an honor and a privilege to be your mommy. Oh, snarky nose.
So that's an interesting psychological dimension to that phenomenon. But I don't want to get too far down that rabbit hole because Click is laying out the groundwork for how we're going to see this discussion get framed. And I think it's important for us to continue listening to what he has to say. Here we go.
Gender affirmation therapy is a type of therapy that is supported by intimidation, fear, manipulation, and isolation rather than education, information, and patience. What happens? A parent brings their child in for counseling and says, I'm really concerned. My child says that they want to be the opposite sex, that they're saying they are the opposite sex, and we're not just really sure about this. What happens, and this story is repeated over and over again, is the therapist will look at the parents and say, do you want a living son or a dead daughter? That's highly manipulative language. And parents love their kids, but they may be resistant, but they're like, what parent doesn't want to save their child's life? And so they're bullied into this gender affirming therapy. And when we're talking about gender affirming therapy, we're not talking about just cross dressing. We're talking about administering hormone blockers and cross sex hormones to these children. And we can actually read here, the pediatrician said, this is a father giving testimony, if I didn't affirm my daughter's identity, and if I didn't get her the help that she needed, and she killed herself, I was going to feel awful guilty. He said that right there in front of my daughter. That is not professional counseling. That is manipulation, my friends.
So that was his section on this phenomenon of suicide being used as a lever to engage in therapy. He uses that this therapy is implemented under a shadow of threats, intimidation, and manipulation. When you hear that, you could say he's trying to paint these clinicians, these therapists, as evil, nefarious people. And I think it's possible to look at this and say the effect that the parents may feel is that of being threatened, being manipulated, because they're confronted with this choice, this black and white choice of accept the gender affirmation or your child will die. And that carries a bunch of assumptions, both that the claim that your child will kill themselves is real, but also that the affirmative therapy is going to solve the problem of their depression and their suicidality. And it's true, the parents will feel threatened and will feel manipulated. And so they'll characterize this process as being done under the shadow of threats and manipulation. The clinicians, however, they carry the assumptions that this high suicide rate is very real and that they've got to persuade these parents who may be blind to their clinical insight about what the best way forward for their kids is. And one of the things that we're learning is that clinicians don't actually have the right data or the full picture of the strength of the evidence of their belief that these therapies are going to have the effects that they want them to have. And there's a really important article by Julia Mason and others that hitting the presses soon, if not already, that I was able to look at, where they look at the foundational claims of the original Dutch study that was used to justify all of these therapies, and they show how it really does not bear out to scrutiny. But if you go and you ask these clinicians, how certain are you that this therapy is going to have the positive effect that you assume it's going to have, they will place a high degree of confidence in that. And we'll hear that in the witness testimony from the various gender clinics. But if you're only getting a piece of the information, or only information that is filtered through a very ideological lens, and only the information that the activists want you to see, the activists being this name for people who want to see only one answer to all of these things, which is that gender affirmation, which, as we will come to see, people with that perspective in the health professions are shaping how studies are being performed and being published, being broadcast. And it's distorting our what should be normal evidence-based process of learning about this therapy and this patient population. Then the perspective of those gender clinicians is going to be distorted. And they're going to feel like they're working in the patient's best interest to bring up the specter of suicide. But if you just step back and say, we are advised that you should not be making life-altering decisions if you are in such a mental state that you are depressed and suicidal. That is the exact time where you don't want to be making irreversible life-altering decisions. But that very thing is being used as the wedge to cause people to go down this pathway, and it does not make sense. And if you go back and you look at the Dutch study, that was the very people that they excluded from these therapies. And yet that's what we're arguing for these therapies directly to be applied to, is patients in those situations. Anyway, anything to add there?
Yeah, I have a few things to add. Even though you do state it's not the best time to make a decision about some sort of intervention in a child's life when you're under a state of discomfort, distress, disorientation, and you're faced with kind of just the person in front of you, maybe two people, maybe just one, giving you information. Sometimes, I would say a lot of times, yeah, you need to make some decision, and that decision may be inaction. You may decide to do nothing. It used to be the watchful waiting approach. So you may decide to intervene and do something that they recommend. But to assume that there is some ideal situation in which people can make medical decisions in a vacuum of distress, I don't think is probably reasonable, to be honest. So we do know that people are coming to the doctor with their distressed child. They're distressed, and the reason that they're coming is because the child is in distress, which is making the parent distressed. And then they have to make some decision. So, of course, that's not in a vacuum. It has to happen anyway. Is it ideal? No, not at all. But I do want to also say that my assumption is never that there are some sort of nefarious players in the front end business of all of this. I don't think that even Amber Briggle, for example, or even any of the psychologists, I don't think that they're actively trying to harm people. I don't think that. I actually think that most people think that they're doing good things. I think that most people are coming from a place that they believe that their actions are good and that they are helping either themselves or they're helping other people. So if we come from that idea that the actions of people are inherently oriented toward the positive, then the parent who comes to the clinic and says, hey, my kid is in distress, I'm not sure what to do, whatever decision that parent makes from that point forward is oriented toward helping their child, even if they decide to put the child on puberty blockers, cross-sex hormones, and remove their genitals. They're doing it because they think it's a good action and it's going to help their child. The information that they're given that would tell them that's a good decision is coming from somebody else generally. It's generally not an internal kind of feeling. It's generally something that they're given. And of course, they're given a somewhat limited information because in general, we have limited information. And so we still have to make decisions. Even with limited information, we still have to make decisions. And that decision, like I said, might be inaction. But there's consequences to the inaction decision. If you do nothing, which in my case, what was that? I said, no, I'm not going to have an intervention for my child. I don't think that's appropriate. I'm not going to intervene by using some other pronouns that aren't biologically based. I'm not going to use this other name. That inaction is actually considered harmful, and I'm not participating in the psychological recommendation, given the evidence that I could see on that. And there's consequences. I don't have custody of my child. There's a real consequence to that. And I know parents personally who I've talked to who have had Child Protective Services called on them as soon as they said to the doctor, the psychiatrist, pediatrician, psychologist, all of these, I don't think we're actually going to do any of those things. I think I'm going to take her home. And within 48 hours, they had Child Protective Services at their door. So that choice has consequences, even the inaction choice. So then the other choice is that you're faced with a social worker generally, maybe a pediatrician. And that pediatrician is coming from the point of view of, I don't want your child to die either. And the limited evidence that we have, or that I am being told, because I basically have patients all day and I have a family and a life and all these other things, and this isn't the only thing that I deal with. This information that I've been given is telling me that it would be ethical for me to tell you to intervene in this way. The stuff that I'm telling you is to try to prevent harm to your child. And so I'm encouraging you to do this because from the doctor's point of view, they're thinking this is an ethical thing.
And you have a pediatrician who's not specialized in that. So all they can do is point to, well, these professional societies say it's right. I trust them to have reviewed the evidence. And so I'm going to endorse what they say. And they have that to have faith in and to lean on in making those recommendations.
Same thing with the psychologists, or mostly these are social workers. In gender clinics is how we describe them, adolescent gender development, whatever that means. Those are people who are thinking this is actually the right and good thing for children, that they will honestly die if they're not affirmed in this and we don't continue down this positive reinforcement affirmation model. I don't think that there's something nefarious about it. I don't think they're malicious. Lots of people would disagree with me on that. I'm okay with that. I do think that people are good, and I do think they're motivated by helping people, for sure.
What we're going to hear when we hear the experts come and talk about watchful waiting is they make the point, they say, we want to make it clear that watchful waiting is not doing nothing. It's still engaging in a form of exploratory conversational psychotherapy that is aimed at looking at these comorbid factors and addressing them because they are clearly affecting this individual's life. And so I think the choice that people are making between irreversible, significant changes and conversational therapy that is looking at exploring all aspects of the individual, there's different weighting that you would give to those in terms of should we go down this pathway at a moment of distress? And if it's something that carries those heavy irreversible consequences compared to something that we have a known track record works, then it's an ethical choice to say, let's do this watchful waiting that is not simply passive waiting, but psychotherapy, the type of therapy that anybody having any sort of difficulties in their life with that regard would go down. Your point about the advice that's given to parents that you immediately adopt a new name, use the pronouns, do all of that positive affirmation at home, that is a psychological intervention that is on the route of putting them on the trans train to hormones and surgical intervention in the future.
I want to make 2 points. So, one around Gary Click's example. It's interesting. He uses this term that the parent may feel threatened or manipulated. And you had even said that earlier. I'm not sure that a parent in that situation necessarily feels that immediately threatened and manipulated. I think in retrospect, if they make a choice, and I talked to a parent 2 days ago that was encouraged to put their child on puberty blockers and cross-sex hormones, and now that 21-year-old boy seems to be suffering from erectile dysfunction and sterility. The parent now may feel like she was manipulated and threatened, but at the time, I'm not sure that she felt that way at all. I think that she wasn't feeling that way. I think she was probably feeling supported, encouraged. I think she actually probably had a positive experience. And now she's looking back and thinking, that's not what happened at all. So I think there's that.
I see your point there. And that dimension of manipulation can maybe only become something you realize when you see what information was held from you. When the risk factors, the downstream consequences aren't presented to you as you make that decision, then you may only in retrospect be able to say, hey, wait a second, I wasn't given the full picture when I made that decision. It was a form of manipulation.
Yeah. The other point is that when you're walking into, let's say, Lori's a gender clinic here in Chicago or any of the others, it's not an emergency room. There's a difference between a child kind of saying, I wish I weren't alive, and people who can evaluate suicide risk, know all of these things. There's a checklist. There's the difference between, I wish I wasn't alive and I have a plan to kill myself, and this is it. There's a whole bunch of degrees in between there. So to say that when you're inside a room, let's say Gary Click's example of the pediatrician, and I've heard this so many times, it's painful when the pediatrician says in front of the child to the parent that if you don't do this, your child is more likely to kill themselves. And how would you feel about that is generally what they say, that you contributed to that in some way. And the child then has this idea, oh my gosh, if I don't get this, I might have to kill myself. That's pretty terrible manipulation and coercion, I would say. But what's the reality of that actually? This isn't an emergency room. There's no emergency happening right now. The child is not activating a suicide plan at that exact moment. I'm not saying that what's happening in the child's life is not important and needs to be addressed, but it's actually not an emergency that you need to make a decision immediately to get the next appointment to intervene in the possible death of a child. That's not true. There's nothing that says that. And if that's true, your child should be in the emergency room. So I think that's so false. The idea that it is imminent death. It's not true. It's not true.
And you compare that with the story we're hearing from transitioners who were influenced by social media on Tumblr and TikTok and other forums where they say, yeah, there were people who were telling us that if you want to get this therapies, you need to use the threat of suicide because that will really start the ball rolling. And so there's a coaching into how to get the therapies that you want. And many of these families, not only are they faced with a kid who is in distress, but this kid's distress takes on a character of urgency. I need these therapies now. And the urgency is tied to this clock of puberty, where puberty is going to start these changes in their body. And if they don't stop them now, then it's going to be dire in their effects. But a lot of these ideas about the urgency, about the negative consequences of it, are in some way shaped by social media influencing how these kids perceive these issues affecting their lives. And that's manifest in the profile of particularly the population of rapid onset gender dysphoria, where it seems like social media is always present in the lives of the people who experience these things. They start to experience gender dysphoria and the sense of urgency after they have had a phone or a computer that gives them access to these ideas, these groups. And the degree to which social media and discussion forums can shape how a child frames this idea is really revealed when you listen to the stories of the now detransitioners talking about how they went down that rabbit hole of gender ideology and started to reshape their experience as adolescent young women going through normal puberty.
So I think all of this and the entire thing that we're looking at is all within a social cultural context. And getting to this legislation and testimony and what the legislators are presented with and how they are hopefully going to come to what they think is the obvious choice of voting in favor or against this piece of legislation. They're getting some testimony. They're getting all kinds of things coming to them. And the thing is, they're not actually a jury. This isn't actually some sort of, and that they're only allowed to take into account the evidence presented in front of them. That's not actually how this works. They're in a social and cultural context. They're not told that they can only consider the evidence in front of them. So it's different.
So you're saying that they may be looking at the political ramifications of their choice. They may be looking at what the consequences for them personally are. The other dimension of this is you don't hear it so much here, but the halls outside of this hearing especially in the later sessions, are filled with protesters making a whole bunch of noise. And it breaks through into the hearings every once in a while, but there are people that are responding very vigorously to what is going on in these rooms as it's happening.
And I would love to tell you that they were in the hall, but they positioned themselves outside the windows, outside. They
Really?
were physically outside in a large group. Outside this building is quite large. They knew exactly where the hearing would be taking place, and so they were outside the windows of a building that is probably not new double-paned glass. It was purposeful so that they could be caught on audio because you can't demonstrate like that within the halls of the legislature. They used the
All
public
right.
space to interrupt.
Okay, let's see where he goes next.
That the most advised method by professionals is watchful waiting. Watchful waiting says, let's just take our time. We don't affirm the child, but we don't disaffirm the child. We don't try to lay guilt on the child. We don't try to change the child's feeling, but let's just, son, daughter, whatever, let's just take our time with this. Let's explore this. Let's not rush things. And that is recommended by such professionals. And everyone tells us to listen to the professionals, but they only want to listen to the professionals that they want to listen to. Dr. Kenneth Zucker. Dr. Kenneth Zucker is the foremost authority on gender dysphoria, probably in the world. Dr. Zucker was the chairman of this division of the DSM-4 and the DSM-5, which is the Diagnostic and Statistical Manual. And he chaired the division that wrote about gender dysphoria. It used to be called gender identity disorder. They changed the name in order to take away the stigmatism of it being a disorder. And he advocates for watchful waiting. Dr. Stephen Levine was the chair of the 5th edition of the World Professional Association of Transgender Health, commonly known as WPATH. He chaired the 5th edition of their standards of care. And so certainly is open to this, open to transition and so forth. But he says, not for children. He advises watchful waiting. Dr. James Cantor is a neurologist specializing in the field of sexology. He is also a progressive. He is also a member of the LGBT community. He has written a paper that is entitled The Transsexual Bill of Rights. And he has a list of all the ways that you should show respect to transgendered individuals, including using proper pronouns and so on and so forth. But he advocates for watchful waiting. In fact, he has authored a blistering rebuke to the American Academy of Pediatrics recommendations for gender-affirming care for pediatrics. We're talking about a professional, someone who knows this, someone who is sympathetic with the trans community. Dr. Deborah So is also a neurologist specializing in the field of sexology. She's a fierce advocate for the LGBT community, and she takes the same position. Dr. Lisa Littman is I guess she would probably describe herself as a flaming liberal. She would never vote for anybody on this side of the aisle. She'd only vote for this side of the aisle. And she has done some research on this, and she advocates for watchful waiting as well. In fact, she discovered the phenomenon that is commonly known now as ROGD, which is rapid onset gender dysphoria, which is a social contagion that takes place mostly amongst teenage girls. And it comes after exposure to a lot of social media and so forth. You can go on YouTube all day long and you can find people who are giving these videos about their transition timeline and how wonderful it was and how wonderful it made them feel. And some people, some young girls watch that, get into that, and some young guys, and they think that is the answer to all of their problems, and it's not. Stella O'Malley and Sasha Ayad are gender specialists who also produce a podcast by the name of Gender, A Wider Lens, and they are gender therapists, and they also, one of them identified as transgender as a child, and they both advocate for watchful waiting. Watchful waiting is non-judgmental. It does not pass judgment, but it gives a time to a child to grow up and figure these things out. What's important to know as we look at this in watchful waiting is that 85 to 95%, and this is a statistic that's all over the place. You can find it. I think we footnoted it. 85 to 95% of children with dysphoria will desist after puberty. Puberty is the natural answer to gender dysphoria for most children. Not for all, but for most. They will desist. But when you give that child puberty blockers, which they say is a pause, it's not a pause, because 95 to 100% of children who go on puberty blockers will not desist because they do not go through puberty, and they go on to cross-sex hormones, which are dangerous for them, and ultimately to surgery, which is irreversible. And I think I'm getting ahead of myself into the risk factors.
Okay, so he just laid out a number of experts, professionals in the field of gender therapy who don't agree with this affirmation only model, which immediately instills social transition, hormone blockers, cross sex hormones, and surgery. And it reveals how well read he is on this subject because he goes to the professionals, including Ken Zucker, Stephen Levine, who because they themselves were involved in the care of this, particularly Stephen Levine having chaired the standards of care by WPATH. When you listen to people talk about how WPATH has evolved over the years, it has changed. And there was a time where it was attempting to and was primarily much more medical, scientific, ethically based, but it has always had an activist dimension to it. And as certain activist components have become more powerful, the people who entered into that organization from a medical, ethical perspective have been pushed out because they wanted to talk about the risk factors. They wanted to talk about putting the brakes and holding on and not simply pushing forward with an affirmation only model. And when those people get pushed out, then different things may happen. Ken Zucker, in particular, was targeted by activist groups, some of whom were prior patients who fabricated accusations against him that led to him losing his clinic, losing his credentials, and losing his position. And when that case was reviewed later, he was paid a settlement because it was based on false accusations, and his institution caved into that activist pressure, depriving him of his spot and damaging and tarnishing his reputation. So if you go out and Google who's this Ken Zucker guy, you're going to see a lot of negative stuff. But that negative stuff is the result of a smear campaign because he did not step in line with the affirmation only process. And if you don't step in that line, they will smear you as a bigot and then come up with some way to delegitimize you, which is what happened to him, even though his credentials up to that point were impeccable on this issue.
There's something I want to say that I think Gary Click is doing in this is he's taking people who are looking at this from a different perspective, who don't have the professional association standing. Some of them are new to looking at this or have been looking at it, but they didn't do how do I say this? I want to say this in a better way. Let me start over. So what Gary Click is doing as he's listing out all of these professionals is he's saying that there is some dispute within this community, and he's trying to give at least a small view of what that is, what that dispute is. Now, I'm quite familiar with all of these disputes and all of the people, characters, whatever, that are going on within this. But he's giving some examples of individuals that somebody can look up. They can Google that person and figure out what's going on, and they can read their original research. They can listen to the Gender Wider Lens podcast, and they can look up Ken Zucker. They can get some more information on their own if they're looking at individuals, because we know that associations are made up of individuals. So what you were just describing is the kind of overtaking of associations by individuals that have a certain personal interest and gaining control of the documents and recommendations that come out of an association, a bit less based in ethical considerations for what is best for children and maybe even families. So I think that's something that he's trying to address. I don't know that it's still in our cultural, social moment in time. There is a lot of dispute around that, and that will play itself out over time, and then we'll be able to look back. Now we can look back on Ken Zucker and say, oh, he was vindicated. That the things that they were saying at that time, it was probably the worst time in his entire life. And now we can look back and say, oh, none of those things were true. He was doing good ethical work. But unfortunately, the damage has been done to his own reputation and the trajectory of how we treat children. And that's really unfortunate. But that's true of any moment in time, that we will have some perspective in 10 to 20 years. But I think what Gary Click is asking us to consider is how much damage we really want to be done. Because we do have to make a decision right now, no matter how much pressure we're under and how much little evidence we have we actually do have to make a decision now. And he's saying, I have this bill and I want us to make a decision on it. And we're going to hear some evidence around that. The second thing that I want to bring up is the thing that he mentioned quite briefly, but is actually a giant thing, is the move to stop calling gender identity issues a disorder. The idea of a disorder is that it is something is wrong. There is something, an idea that is not based in reality. It is some sort of false thinking, something that does not have evidence behind it, a disordered or cognitive error. And if it comes to such an extreme case, it is a disorder. I'm not sure how we could not call this a disorder. I'm not sure how you can say that if I have a female body that can be measured in a bunch of different ways, physically based upon, let's say, how far back my eyes are set, or my own DNA or ability to produce like large gametes, and that somehow my perception is that I am a man based upon the general going definition of what man is, I'm not sure how that's not a disorder. So I think it's pretty obvious to me, and I think it would be to 99 plus % of the people I encounter on the street, that's a disordered thought. There's an error happening there with the general definition of what it means to be a man or a woman and all kinds of measurable, material, objective characteristics of the physical body of a person. He skipped over it, but it's huge. I would assume, and I do know, that there is a bunch of political stuff around the word disorder. And like he describes, and well, like you described, there has been a shift toward who is making decisions around language and what it means and why they chose to remove the word disorder. I think the reasoning that he described, that it is around stigma, that would mean that we should remove the word disorder entirely from every single condition that exists because we want to destigmatize mental illness, don't we? I thought that was our whole thing we were moving toward, was destigmatizing mental illness. So how is anything a disorder then? So I'm not sure that's the real reason. I think he said that, but I think if somebody dug into that a little bit more, they would realize that, gosh, the word disorder was removed from that one. I wonder why somebody would want to remove the word disorder from that, gender identity issues. There seems to be some reasoning there. It seems like something that you can measure objectively and biologically, that you're matching a word such as man to a female body. That seems the most obvious of disordered thoughts. I'm not sure why anybody would think that is not a disorder.
It starts from your premises, and if you assume that there is such thing as a trans being that is ineffably and objectively trans, then you can't assume that kids that are trans, that are confronted with a society that's not ready to accept them, that's not a disorder of the individual, it's a disorder of society. Then you can say their dysphoria is not because of their mind dealing with an idea that does not comport to reality, but their disorder is their self-existing in a society that doesn't accept the reality of their transness. So all of these things carry on these assumptions that are based on these starting premises. And I think looking behind that change and saying there's something to it, what that change from disorder to dysphoria says that there's already an ideologically driven activist component that is influencing the way that we categorize these processes that are affected by our health profession. And if it can affect the DSM, it can affect anybody along the way. And the great thing about him listing off these names is you can Google Stephen Levine, you can Google Ken Zucker, James Cantor, Sasha Ayad, and Stella O'Malley, all these different things, Deborah So, each of them has intersected with this issue in different ways. Ken Zucker, certainly on the issue of how we intervene. Stephen Levine on whether or not we address all of these different comorbid ideas, the comorbid psychological disorders that may underline the experience of gender dysphoria. Deborah So on what is the actual evidence behind studies that have looked at differences between gender. She has a book called The End of Gender that goes in depth into all of the science behind that. So whenever you hear people say the science is settled, if you only listen to one side of the argument, you may believe that the science is settled, but it's only when you listen to the critics and the dissenting voices that you can realize that there is real reason to not simply take one side at its word and not be curious about everything else, which is why it's so nice that he says the remarkable thing about this is that there seems to be some professional incuriosity about the whole landscape. And some of that is they're busy doctors. Your pediatrician is trying to wrestle all the clinics, all the patients that they have every day. They don't have time to go into depth onto these things or even to train on them. And so they defer to the gender clinic. And everybody that is doing medicine just defers to the gender clinic. But if the gender clinic is populated by clinicians that only adhere to this one perspective, then that's how a system gets captured. And I think that's why states are turning to their legislative boards saying we've got to do something, because there's only one answer to a very complex situation that is being presented to us as parents dealing with kids with this issue. Okay, let's keep going with Gary Click. Let's see what he goes next.
But notice this. Here's what the leading therapists who do not advocate for watchful waiting, even they will say this. They say, gradually throughout adolescence, teens learn greater self-control. However, before that occurs, especially in early and middle adolescence, they tend to engage in risky behaviors as they are more focused on immediate gratification. As their brains develop the ability to think through the potential consequences of their actions, teens frequently act in ways that can jeopardize their social, physical, sexual, and emotional safety. And as they mature, they are more able to synchronize their behaviors with the increased recognition of potential negative impacts of impulsive decisions, as well as align their actions with emerging awareness of their long-term goals. And that came, it's the only scientific thing in the book, but this came from the Transgender Teen, a handbook for parents and professionals supporting transgender and non-binary teens. This is a go-to book, and they tell you that about a child's mind. And I thank you for your patience. I'm very close to being done, Chair. Thank you for your indulgence. But we want to look at some risk factors. Dr. Quentin L. Van Meter of the American College of Pediatrics warns that the grave side effects of transgendering include, but are not limited to, sterility, sexual dysfunction, blood clots, strokes, cardiac disease, osteoporosis, malignancy, and persistently elevated rates of suicide. Children and teens do not have the cognitive capacity to fully comprehend these risks. The manufacturers of Lupron Depot, which is the go-to drug for puberty blockers, they list the causes on their website, the uses of Lupron, or for men with prostate cancer, for women with endometriosis, and also with fibroids, and for central precocious puberty. The use of this for gender affirmation is off-label, is not recommended by the FDA. And so it's an off-label use. We read elsewhere, according to the American College of Pediatrics, in an article entitled Affirming Sex Change in Kids Violates the First Do No Harm. Dr. Zenga writes, and you can see his credentials up here, puberty is normal, natural occurrence. Puberty blocking drugs create an abnormal condition that arrests a child's brain development as well as their physical sex characteristics. When combined with or followed by cross-sex hormones, they often result in permanent sterility, including permanent sterility. Cross-sex hormones in and of themselves are associated with debilitating health risks, including heart attacks, stroke, diabetes, cancers, and more. In addition, rates of suicide are nearly 20 times greater among adults who've used cross-sex hormones and have undergone sex reassignment surgery, even in Sweden, which is among the most transgender affirming nations in the country. And so let's look at suicide by the numbers.
And Representative Click, I do very much appreciate your attention to detail. We typically do about a 5-minute limit, so we're at about 10 minutes. So if you could get to the
Very
conclusion.
good. I appreciate that.
I know that members are very interested in asking questions, and I do want to allow
And I
time
want
for
to
that.
entertain
Thank you.
that. And if you would like to move, let me just close with it. I'll skip a couple pages here and you can read it. Thank you for your patience, Chairman.
Certainly. And I will just advise members, it is all on your iPads. And so I encourage you all to read through the detailed analysis that he's provided for us. Thank you.
It is hard to cram several months of reading and several hours of study and all of this into 10 minutes and make an effective statement. And I knew that was my challenge from the beginning. My first testimony was 25 pages. I've worked on it, but thank you for your indulgence. Really, what this amounts to is informed consent. A child does not have the ability to consent. They do not have the ability to look forward, to look ahead. If you will pay attention, if you just Google detransitioners, you'll find on YouTube tons and tons of people who've gone through this process and then tried to undo it. The average age, according to Dr. Lisa Littman, that takes place is the age of 24, which ironically is the same age that the prefrontal cortex of the brain becomes fully developed. Young people do not have the ability. I have some cases in here that are described for you from law and so forth. But what we're really trying to say here, and I will wrap up with this, and I will ask you to read this testimony because it contains a lot of facts. It contains a lot of references to it. But there are just simply some things that kids cannot do and not allowed to do in Ohio and in many places around the world. Children cannot purchase alcohol or cigarettes or participate in gaming-related activities. Obviously, we all know that they cannot consent to sex under the age of 13 and may not consent to sex with an adult over the age of 13. Some other things I found that are interesting is that they cannot vote, hold office, marry, or buy or possess firearms. They cannot even play bingo. And they cannot donate blood under the age of 16, and because of informed consent. And so we need to make sure that before we start doing all these things, and please pay attention to the health factors, the health risks, we should not be able to sterilize children through the use of chemicals that leads to irreversible damage in these children because they cannot provide informed consent. When they are of the age of 18, they are free to do as they please. And they are free to pursue whatever life course and life path that they think best suits them. But children are not capable of making those decisions. And so I would urge you to support House Bill 454. And thank you for your patience in that process. And I am happy to entertain your questions.
All right. So he finishes his closing statement. What do you think?
I think it's funny how a kid isn't allowed to blow $20 on bingo, but can somehow make or at least participate in the decision-making process of a lifetime of erectile dysfunction. I think it's crazy. I think that if Martians were looking at this video, they would think we were bonkers. I honestly do. It's a really crazy, like I described, cultural moment that we're living in. That's absolutely horrifying.
It does seem off the rails.
It seems crazy. So his examples, of course, do not make sense if you think that, there's no such thing as a transgender child and they were born in the wrong body. But if you believe that, then you're saving the life of this child. You may be limiting the number of years the child is alive. You may be changing or diminishing the quality of life of the child, but you're saving their actual life is the argument. I can understand how if somebody really believes that, they think that the affirmation model is the right choice to make. So I can understand how this is a real debate, but I would say the vast majority of people that you talk to on the street think that this is insane.
I love how he frames it and says basically, with all of this evidence, all the data, all the testimony, what you're going to hear, what you need to drill down on is this issue of informed consent. And from the medical perspective, informed consent carries a lot of baggage with it. Not only does it carry the idea that we're giving agency to the individual. If they're a minor, then the concept is that the parents do the consent and a child assents to the treatment. And that nuance will come out in the testimony. But the idea is that they have to be of sound mind. They have to be able to weigh the options and make a decision. And if you have somebody who is impaired in their ability, even if they're an adult, they cannot give informed consent because they don't have the maturity, the ability, the cognitive capacity to understand the issues. And he starts out by observing that even people who are activists for this cause acknowledge that kids are not in a position to be able to make those types of weighty decisions that will affect the rest of their life. There's impulsivity, there's lack of judgment, there's lack of life experience. There's all different aspects to the concept. The reason that we don't allow that list of things like tattoos and bingo and so forth is because we acknowledge that kids cannot consent to these things that have irreversible life-changing damage or consequences in some cases. Speaking of things like voluntary sterilization or tattoos, those are things that are hard to reverse. And then kids are also susceptible to some things that we know can latch on to a person and take them down pathways, things like gambling addiction and things like that, that kids who may not be capable of realizing those psychological forces and taking steps to prevent themselves from being swept away with them. Those are all dimensions to this concept that informed consent has to be at the center of how we analyze this issue. Now, that dimension of the person has to be able to make the decision and be competent to make the decision is one dimension of informed consent. But the other aspect of informed consent is that when we're trying to present a course of therapy to a patient, they have to understand the positive outcomes that they could receive from the therapy, as well as the side effects. And then they have to understand how likely is any of these potential complications is the benefit that they have. Because if there's a therapy where you could have a great benefit, but there's a very large complication rate, and those complications are severe,
Serious, yeah.
then the benefit may not actually weigh sufficiently to enact this therapy in the population. But if you're never presenting the patient with the full picture of what those risks are, what those complications are, then you're depriving them of a legitimate informed consent because you're missing the informed component of it. But it even goes further than that, because it's not only that you have to present them with the benefits and the risks of the procedure, but you also have to present them with alternative therapies and what they would be rejecting if they went down one side of therapy. And that part of this conversation is never included, because the alternative therapy that you would need to present to these patients is you'd have to tell the patient, okay, you tell the patient and the family, we could take you down this pathway of social transition, puberty blockers, surgery, and everything. And that's one pathway. Here are all the risks of everything. If you end the conversation there, then you're not saying, also, we could do this watchful waiting thing where we sit you down with a therapist in a regular time and we just explore these things and give this some time, slow things down. We're not going to start these things. Now, it turns out if you do that, a majority of the patients will have this experience of gender dysphoria resolve, and they'll go on and live their life with the challenges that we all face every day. Whereas if we take you down this pathway of social transition and hormone blockers, you're going to end up getting cross-sex hormones, and you're going to end up getting surgeries. And with those surgeries that have a high complication rate and where you're surgically castrating yourself, where you deprive yourself of the potential for any future children or offspring or family in that domain, and you're committing yourself to going to doctors' offices regularly to get your cross-sex hormones and all of the different downstream effects of that. And not on top of that, that when we study this population of people, they're 19 times more likely not to have thought about suicide, but to have committed suicide 30 years later. You're never presenting those two different pathways to the patient, to the parents, so that they can make a decision of maybe we should give this watchful waiting, which already has a majority of patients resolving, versus this other pathway in which by intervening with those puberty blockers, you're locking them into, virtually locking them into, like when we say 98% to 100% of patients that start those puberty blockers end up going on, that's not proof that we did the right thing. That's proof that you are intervening in a way that sets off a cascade of subsequent therapies. And the way that you can know that is you look at what happens when you don't do that initial intervention. And that's what that watchful waiting paradigm is. So informed consent is complicated, but it's at the center of all of this because the person has to be competent. Kids are not. And parents that are trusting the physicians to make the decision for them, believing that the physicians have been informed of all different sides of it, that if that assumption is incorrect, then they may be displacing the decision for this on what they believe to be a trusted source that may not be giving them the full picture. So on top of that, these therapies, the basis upon which they claim to have a positive effect, as we will learn, is not as strong as you might think. And then if this other pathway of watchful waiting is completely just left outside of the consideration, then you're depriving families of making a choice that we know has a proven track record in a majority of patients of leading to the resolution of this condition of gender dysphoria. So it's a long, convoluted way to say that I think Click summarized it really well in setting the tone for how we can look at this issue going forward.
So I do want to say something, a couple of things. I usually have a couple of things I've realized. One is the concept of informed consent for a psychological condition. If somebody is in, let's say, major depressive disorder or let's say schizophrenic, the capability of them making a decision about the treatment is complicated. But what we're generally talking about in a psychological condition, like either of those, or disorder, is psychological treatment, maybe pharmaceuticals that could be a pharmaceutical intervention that could be stopped or started that has, if you stop it, nothing changed really about the rest of your body. Exactly. It really maybe changed some brain chemicals and the way that your brain functions. But generally, those psychopharmaceutical kind of interventions for something like schizophrenia don't make you sterile. So consenting to treatment when you're not in a position psychologically to consent in the ideal, like we talked about before, is okay in your depressive disorder, your anxiety disorder, your schizophrenia, your number of other disorders, because you're talking about psychological treatment, which is somebody kind of talking to you. Right?
No, stakes are different.
It's a little different. Even the pharmaceutical intervention, none of which would make your arm go numb or your voice change permanently. So that's totally different. This gender identity disorder, I will continue to call it that, is a psychological condition. And in the regular informed consent model, yes, even in a state of not being able to make a clear informed consent because of your psychological condition, you still do make the best decision possible at that moment, given the circumstances in your psychological condition. And like you said, there are certain ramifications to that. Now, we say that a 13-year-old is not actually making that decision because they're assenting. They're not saying no, but they're not exactly the person to say yes. The person to say, I want this, is the parent. And again, the parent, as we previously discussed, is also in a state of distress in making this decision. They're concerned about their child. They have a lot of pressure on them, and they're given little information, limited information, maybe all the information that can be given by that pediatrician or that social worker or something. Maybe that's just a sliver of anything. So informed consent is super complicated. How informed can you be in a state of psychological distress? So that's number one. The second thing that you brought up is so fascinating, which is, don't we want a bunch of different options to choose from? Isn't this America? I want to walk into the grocery store and have different types of ketchup. And I would like to be able to choose whether I go to a homeopathic doctor or I go to somewhere to have surgery for my cancer. Like a lot of options. Maybe I just want to let cancer slowly kill me and enjoy time with my family in my house instead of in a hospital setting. All of those things are possible. Nobody is going to remove my children from me if I decide to live with my cancer in my home. It's not going to happen. It's a little bit different when we're talking about actual children and things like blood transfusions. I think you probably have a bunch of information on this. There's a bunch of Supreme Court cases on whether or not you can withhold blood transfusions and different procedures from children if you have a certain religious belief. There is some Supreme Court cases on this. This is not one of those things. We're not talking about a physical ailment. We can all agree, I believe, that we are not talking about a physical ailment unless you believe that you were born in the wrong body.
Yeah.
Right?
Yeah,
Then
it goes
it's a
back to
physical
those
ailment.
starting assumptions.
Yeah, something has to change. So does the mind change or does the body change? I'm a fan of the mind can change because the mind can change back and around and all of these other things. Once you remove your genitals, you really can't sew them back on and they don't function the same way anyway. So I'm not a fan of the whole physical change idea. I would rather change my mind, which is, again, that the 13 types of ketchup idea, which is affirmation is one model of care. And then there are probably 1,000 different other ways that you could go about doing this. So it's not just an either or, it's actually a plethora of things that you could do as interventions or non-interventions, but in no other case would you say this is the only way that we do this. Not even with life-threatening physical problems like cancer. We don't even say that there's only one way there.
All right. So now he's laid out his case. And as you will see in all of the other testimony, Ohio has a unique thing where I suppose in order to try to minimize interpersonal conflict, everybody has to submit their questions and responses through the chair to the individual. And so you're going to hear a lot of people tripping over that paradigm, but it's a fun dynamic of how these hearings go. After a witness gives their initial statement, which should usually take around 5 minutes, then they're hammered with a litany of questions from different people on the committee. And this is our first foray into this Q&A session. And you'll start to get a sense of some of the personalities involved. And that was part of what was so fascinating about these Ohio hearings, is you really get a sense of these personalities. So let's go ahead and dive into the first Q&A session with Representative Click.
Thank you, Representative Click. And again, we appreciate your attention to detail and your thorough research of this issue. So thank you for bringing that to us today. Are there any questions for the sponsor, Representative Liston?
Sorry, Rep. Humphries. I preemptively raised my hand. I hope we all have opportunity to ask questions. I have a number, but I'll start with one that's relatively simple. You mentioned that you were asked to carry this bill, and you said our position multiple times. Can you share who asked you to carry this bill and who's the R you're referencing?
I was asked to carry this bill by parents, first of all, and also by me, the Center for Christian Virtue.
A follow-up?
I have a secondary question, or
Sure,
okay,
go for it.
a couple actually. I think there's a fair bit of maybe confusion around some terms, and I just wanted to maybe talk about the concept of gender affirming care. What do you view that to be? Does it match what's currently happening at, for example, the programs at Children's Hospital and how they approach children with gender dysphoria and transgender children? I'm concerned that you're using gender affirming care in a very narrow context as compared to what actually happens. And are you able to clarify that?
Through the chair. I got that written down here because I always forget to say that. Through the chair to Representative Liston, thank you for the question. And I respect you greatly, and you and I have had many discussions on many topics, and I appreciate your expertise. When we're talking about gender, actually what gender means, and I skipped over that part in an attempt to get down the time, Chair, but the word gender has come to mean something that it's never meant before. Today, gender means an inward feeling about who I am. Gender originally was used to describe, gender was a word that was used linguistically to talk about, especially like in Latin and Greek and so forth, to describe words as being masculine or feminine or neuter and so forth like that. That's what it meant. It has always been historically associated with your sex up until recently, when people began describing gender as an inward feeling about your sex. In other words, the idea that you can be a male on the outside, but be a female on the inside. And that is an ideology. That is a philosophy. That's a belief. For some, it's even a religion. The Native Americans use the term two-spirited for that, but it's not science. And so when we talk about when they say gender affirming care, what they mean is, as if a young man identifies as a young female, gender affirming care in their minds means we're affirming him as a female when he's not a female, or vice versa. My perspective, and I think the perspective of many other professionals, is that you're not affirming the gender, you're actually affirming the dysphoria. And so I think we may disagree. I know what people mean by it, but we may disagree on that definition.
So
Does a really good job.
Fantastic job.
Yeah.
He's taking what I like to do, which is let's just back up a second and let's take a look at the terms we're talking about and get out of the weeds. Honestly, let's take a look at this bigger forest. We used to have great discomfort with the word sex. God forbid we said the word sex. And so we started using the term gender because it didn't ring people's ears when you said the word sex, and people go, oh my God, who said sex? This is 5th grade or something.
Yeah.
And so, of course, the word gender is all over the place. And we know it means sex. And that's what he's saying. So that was helpful in that explanation. But even beyond that, he's taking Representative Liston's question that she's asking. She's trying to already, and she'll do this more and more throughout these hearings, she's trying to say, I don't get it. I don't get it. So what do you And the reason that I bring this up right now, because we're going to see it again and again, is she uses this technique that me, as a radical feminist and just an analyzer of women's behavior in general, she's doing this technique that can be valuable. I'm not going to say I haven't done it. I have actually done it. The dumb female, where you're like, I'm sorry. I guess I just don't understand. I guess I'm confused. And what it does is it puts the man in some position of authority. That's the woman is trying to elevate him by diminishing herself. But what she's really going to do is she's going to come back up and get him. She thinks she's going to do that. But the way that you do it is you're bringing him, saying, okay, I'm lower than you. I'm dumb. I don't understand this. You're saying things that I don't understand. What I understand is gender affirmation. I work in this hospital and this is what I hear. And I guess I just don't get it. And if you could explain it to me, come down here and explain it to me, that would be great because I just don't get it. And then when the person comes down, then she gets him. She's got him down there, and then she's gonna think that she's gonna come over him. But this is
Okay,
such
you have a way more
has.
in-depth. You have
I'm
a way
telling
more
you,
in-depth analysis on this
of
than
how
I
she
did.
frames everything is that. And maybe you never know. Did you notice this, Jonathan, when you watched these before?
Well, I noticed that she does have a way of approaching this thing, and I took it not as feigned ignorance, but like in this instance, I think she's okay. He's saying gender affirmative care, and I think he's describing something different from what I know goes on in these clinics or what I feel goes on in these clinics. And so she may be trying to get him either to expose his ignorance or to clarify more. And so I'm not doing the radical
You're
feminist
so
analysis
nice.
of intergendered.
It's not necessarily like a radical feminist orientation or whatever. It's just from my experience and kind of the community of feminists, radical feminists, is a technique, like you're saying, this feigned ignorance, which gets you, this is an attempt. The feigned ignorance is actually an attempt to gain power. So in this particular case, yeah, I think she is trying to clarify for the audience. Let's all get on the same page in terms of terminology, because you're describing something that I'm a pediatrician who works in a hospital. Like, I don't think that's happening at all. And let me tell you what's really happening, because you seem to have gotten some misinformation. So yeah, she's gonna school him on what.
Yeah, and this
what's really
theme
happening.
comes up again and again, where you get the sense that Representative Liston in particular, she's one of these great personalities you're going to become familiar with, but it seems like she believes that all of these Republicans and their cronies and these witnesses are all misrepresenting what the actual medical profession is. And the medical profession is already doing the accepted standard care. And anyone who is saying that they're not doing that is misrepresenting it. And she's just there to expose their misrepresentation.
Yeah.
But that's why it's honestly her exchanges and who we'll meet later, Representative Smith. That's where you're learning the most about the different sides of this issue. And that's why it's so good that Representative Click is so good in explaining this thing. Because the key point that he makes after explaining that the word gender has become something other than what it was is that if you then take this new concept of gender and slap it as a label on the therapy, then you may actually be doing the opposite of what you think you're doing.
Yes.
Because if we believe that we're trying to treat the dysphoria, but we call it gender affirming care, but it's this disconnect between your body and your mind and your assumptions about gender and everything that are the result of the dysphoria, then we actually may be putting you into a mode of going down a road of therapy that's going to make your dysphoria persist rather than helping it to resolve as you come to terms with the reality of your physical body. And that will become more evident as we go along, but he starts it off with just what is a very good, concise explanation of the issue, and keep that in your pocket when you engage with people on this subject. I think he did a great job.
Yeah, I do want to make a point that she's a pediatrician. I'm not dismissing that she has expertise. I'm not saying she doesn't. She does, but we all have limited expertise. And maybe 3-5 years ago, I would have thought that what he was saying and what he will say in other testimonies that I'll hear in Ohio, I might have thought they were crazy too. Wait, they honestly put kids on cross-sex hormones and they do these things after just a few visits? Or like, really?
Yeah, there's no way.
There's no way.
Yes,
There's
that
no
is a
way.
lie.
There's no way. And I would love to say that if I didn't know thousands of parents, hundreds of whom I have had video chats with. I would love to say that I don't believe that and think it's a weird idea if I didn't actually physically meet detransitioners who this happened to and know people personally that this has happened. I would think it was crazy also. Unfortunately, I know different, and I can't unknow that.
Yeah. This comes up a few times when we're here, where there's a difference between what the clinicians say that they do, what the clinics say that they do, and then what we're hearing from families they actually experience. Yeah. And so that disconnect, maybe every industry has this thing where we know what we're supposed to do, but then in the extremities of a moment of a particular case, when we may be tempted to make an exception, we can make those exceptions, but still say, this is what we do.
Correct.
And the Swedish documentary on this issue was really good at bringing that out, where their major childhood clinic would say, if they were ever interviewed, we have a policy, we always require the guardian's consent, and we never treat below a certain age. But then they found medical records where they do things different from that. They confront the leadership, and the leadership would say, there's rare exceptions, but this is what we do. But then it's in those exceptions that all of these stories come out. And so that's why people feel that they need to turn to hearings like this to try to affect a change. So let's keep going and see where he's now given his initial response. And I don't want to gloss over the fact that she knows who's sponsoring this bill, but she needs him to say it so that it can come out and we can plant the idea, oh, it's a Christian group that is sponsoring this bill. It's one of these religious things. And so that is a seed of, we distrust this because it's coming from a religious organization. So let's keep going here.
I guess my follow-up would be, would you agree that care for children who are vulnerable and experiencing gender dysphoria, maybe transgender, is something that's highly individualized and requires the support of counselors, the involvement of parents, teachers, physicians, as well as the child, and that's a complicated space?
So I think I was, through the chair, I think I was trying to say that. I may not have said it as articulately as you did, but that individualized care is not what's happening. Because what we see is happening is, if you don't do anything besides affirming the gender, then you're not treating that child correctly. I think when you treat that child individually, you look for anxiety, you look for depression, you look for anorexia, you look for autism, and you look for all of these comorbidities that are known to be present. And you don't instantly on day one say, yes, you are, but you take your time and you work through this with this child and try to resolve the comorbidities. This book here says, don't take care of the comorbidities first, take care of the gender dysphoria first. And this is a leading book. These are leading authors on this subject. And they say, take care of the dysphoria first, then everything else goes away. And I don't think that's what other professionals recommend. They recommend looking at the comorbidities and perhaps the dysphoria dissipates.
All right, one follow.
Okay. Oh my goodness. He did such a good job there.
Yeah. So one thing I'm watching her, she's saying children with gender dysphoria or transgender kids. She's doing that. Watch her do that, because she can't say that they're both the same thing, because we have lots of examples of people calling themselves trans that never have a diagnosis of gender dysphoria. So that's interesting. That's cool.
Yep. Yeah. But the assumption there then is, if we're going to do these therapies, we're able to distinguish between gender dysphoria and trans. And we know that we can help both of them by lumping them into the same category. But what she's trying to do is she's trying to frame the debate as though the state intervening to say that we've got to limit how we do this is the state saying we have to treat everyone the same way by not allowing puberty blockers and hormone therapy. And she's trying to say, we don't want to make one rule for everyone. It needs to be individualized. That way, the gender clinic is the one that can determine who needs to go on the therapy blockers. And so it's a way of framing it in a way that is oriented towards what she wants. And so he responded brilliantly by agreeing with her that, yes, it is very complicated. We need individualized care, but that's not what we're seeing, because by all of these forces saying affirmation first and only, we're actually eliminating that complexity that can look at the full dimensions of a child and say there's other things going on other than this gender thing. And it's basically this huge gender affirmation hammer that gets thrown down on everyone, rather than being able to say, no, hold on a second, let's slow down. Let's look at everything going on in your life and explore and perhaps resolve those things before we take these irreversible steps that will send you down a cascade of interventions in the future. And so by agreeing with her point that it's complex and we need individual care and pointing out that the affirmation model is the antithesis of individual care, then he's able to turn that on its head. And he's pointing out there's a difference in the way that they think. He brings up a book that he's marked up and referred to in the past that is opposed to his perspective. So he's reading both sides of it to know what the arguments are on both sides. And he's saying these people think it should be affirmation only and first, versus the therapists who are critical of this that say, no, we need to be tailored and specific and look at the complexities of the individual and address those things before we send them on this irreversible pathway with lifelong consequences. Brilliant answer.
I would like to say that Representative Liston, I assume that everybody is speaking from a place of goodness, and she honestly probably believes that children are individually evaluated. The whole picture is looked at. I'm sure she believes that, and most people do. And it would make sense that she would think that as a physician, that they have a gigantic picture of everything, and then they take a look at everything, and they decide whether or not kind of affirmation is the model to go down, or there's some other things going on or whatever. Unfortunately, that's just not true. I'm going to assume that she is just unaware. I don't want to say that she's honestly speaking out of two sides of her mouth. I would say that she may be unaware.
Yeah. There's also this issue of the cart before the horse, and it all depends on what you call the cart and what you call the horse. Because there are people who will say that you are trans and the dysphoria that you're experiencing and perhaps the anxiety and the depression and the suicidality and the anorexia and all these other things are because you're trans. So by treating the gender dysphoria first and only, all these other things are probably going to resolve because we've now changed these other things. And if you start with that assumption and you make that your gold standard assumption, then you are going to perhaps hold the position that Representative Liston has, is that, of course, they're going to do a examination. They're going to look at all these different comorbidities, but then they're going to treat what is the root cause, which is the gender dysphoria. And you start with that assumption because you're not allowed to consider anything else. Because if you do consider that some of these other things may play a role into why you're experiencing gender dysphoria, you're committing conversion therapy. And you don't want to go down that pathway. And then the cart before the horse, if you say, hold on a second, perhaps it's these other complexities that you had a history of trauma, that you have underlying depressive disorder, that you have anxiety, autism, all these other things. These may actually have played a role in you experiencing gender dysphoria. And if we look at explore and then perhaps resolve some of those issues, then who knows, that gender dysphoria may take on a whole different character or resolve in and of itself, and that there's no need to go down those other pathways. And that philosophical difference between what you're calling the cart and the horse plays into how you perceive all of this stuff. And so just realizing when you hear Representative Liston, Representative Smith, and others, they are firmly attached to the idea that it is the dysphoria that is the root of all these other things. And so you do need to treat that as the primary source of the problem. And just understanding that philosophical difference, I think, helps put those things into context where you can see that both sides are trying to approach this from the best interest of the patient. It's just that you have to be careful about your assumptions in that regard.
But remember, I'm going to say, whoa, horsey, because they'll die if you don't affirm. There's that massive assumption sitting over top of all of this, which is it's not an individualized choice, actually, because what we'll hear over many pieces of testimony, particularly opponent testimony, is they'll die. They're going to die.
You're killing kids.
You're killing kids.
Yeah.
Yeah.
You have blood on your hand. You as a committee support this. And so that threat of suicide, even while they'll say, no, we're not trying to manipulate, we're not threatening anyone, it's there. It's always there.
Always there. And so let's err on the side of caution and affirm. Yeah. Let's err on the side of caution because it can't hurt, I guess, is what they're thinking. It can only help. And we actually know it. It hurts.
Societies may not actually realize that. In the case of Sweden, they didn't understand the scope of the problem until 30 years later when they started looking at the long-term results of people who were intervened in this way when they were children and what their life was like going down the fact. And when you look at the life curves, people in that population drop off because they commit suicide. They don't make it to those older decades. And when they, at the end of it, saw that it was 19 times more likely that they would have committed suicide, then that's a sobering fact that you need to reflect on when especially if you're using this justification of, oh, the kids will kill themselves. If you do these interventions, maybe they won't kill themselves now. There's no evidence that that they are going to kill themselves anyway. When they look at those claims, it does not bear out that they have any justification for making that claim. But 20, 30 years down the lane, we may be setting them up to have more problems down the line. Okay, let's keep going.
Comment, then I'll let people go and then hopefully be able to circle back around to another topic. So I guess your contention then is that children are not getting the support to look at other
Yes, ma'am.
comorbid diagnosis. Have you spoken with, for example, the Thrive Center at Nationwide Children's to talk about how they approach kids and what actually happens in Ohio rather than the book?
Okay. So I have, through the chair, I'm getting good at that part now. Through the chair to the representative, I have spoken with a number of people. I have spoken with the Ohio Children's Hospital Association. They were supposed to set up a meeting for me to tour one of the gender clinics in Ohio. That has not happened. I'm waiting on that to happen, and I will be happy to do that.
Yeah, I would invite you to look at it because that is standard of care to provide that sort of holistic support for kids. And I will let that go and let others to come
And
back.
if I can just do one follow-up before we move on to the next question. And I encourage you, because I know you, like I said, I have a lot of respect for you because you do your research. And part of your research, I would ask you to read some of the literature and perhaps watch some of the videos of the detransitioners who talk about how they were not given a full set of care, full standards care, full range of care, but that they were just rushed into. Some of them can get puberty blockers and cross-sex hormones in a half-hour visit. That is happening. Planned Parenthood is actually, you check off 4 boxes and you can get hormonal treatment, not necessarily in Ohio, but it will come to Ohio if we do not take care of it. And just with quote unquote informed consent, you can get your hormones. It is not, standards of care are not what they should be in my estimation.
Okay.
Yeah. There's something so good when she says, "But kids, are kids getting this?" Now, I don't want to ruin the ending where they say that they don't have this data, but that would be true in just about every state. They don't actually collect data. You keep referring to Sweden that actually collects data. The United States doesn't actually do that. So it would be pretty tough to find that data. If they wanted to find it, oh my gosh, you can for sure find it through health insurance records. You can find all of that. Could you determine, for example, that a parent went to the pediatrician or the gender clinic or something and they were prescribed an implanted hormone blocker at that visit? I don't know. Maybe you could determine that through health insurance records. And there is data that is starting to come out, but that's mostly the way that we do have data is through health insurance records, not through hospitals. So they'll say, is that really happening? Do we know that's happening? And we can only have that through anecdotal evidence. We need to start collecting data on that or have people get probably huge grants to collect that data or have the government request that data through their insurance boards to request what is actually happening to children.
And it's odd because it is an experimental therapy in terms of it being off-label and in terms of everybody on both sides admitting we need more information, which they will acknowledge. We need more information so that we can better improve this care. But the way that you do that is you track the complication rate, you track the desistance, the detransition rate, you track all of these different things, but it requires you to initiate research protocols under IRB review that includes tracking this data and having a regular review of it, having a culture of publishing not only positive, but also negative results. And that issue is in those countries that have nationalized medicine where they can, because it's a single unified system, it's a lot easier to track those things. Once they start looking at that data, they're not happy with the way things are going. And that's been the cause of some of them reversing course. But we're so far behind that in terms of how we're conducting things. And as you allude to, once they actually get those hospitals and clinics here and ask them for some of this tangible data, I was just surprised at how little that they had that they could relate to it. But we'll get to that point.
And they're going to make the excuse that they can't share data, even though it's de-identified and it's
right. They're going to bring up HIPAA.
They'll say lots of things about how they can't produce that data. And I would, if there were such a thing as a congressional inquiry, you would actually get that data. And I feel like that might be what we will see in the next decade, sadly. That's what it will take to get actual data. I know that Louisiana has a House resolution that has data that it is requesting. And I can't say for certain, but we anticipate that House resolution will come back with, I'm sorry, we don't have this data. But then what we would have to do is pass some other resolution to collect it. And there we are so many years later.
All right.
Appreciate you raising your hand high. Recognize you for a question.
Thank you, Chairwoman. To the representative, I have a question because it's going to align with Representative Liston's question. So when I was reading the articles and looking at the bill analysis, I think I want to ask you, are you aware that most times, like through the Thrive program at Nationwide Children's, it seems as if they already have to wait until they're 18 most times. And then there's no pressure. It has to be consent between the parent and the doctor. And so I guess this is doubling down on something that's already being done. Especially, there's only a handful of services that are provided anyway, but the Thrive program at the Nationwide Children's Hospital, more than likely than not, they have to wait until they're 18. So much so that at Kaleidoscope Youth Center, they have a group center where they talk about their frustrations and being angry about not being able to transition. And I guess that just proves my point. The point of they have to wait till they're 18 anyway. So what's the point of doubling down?
Through the chair to Representative Humphrey, first of all, again, welcome to committee. And thank you for your thoughtful question and for your research. I have a couple answers to that. The number one answer would be as if they're not transitioning, then this bill should not be a problem for them. But the follow-up on that is that when you say transition, there are multiple parts of transition. And social transition actually begins before chemical transition. And we're not even addressing that in this bill. If you want to have your child dress and change their hairstyle and things differently, that's not addressed in this bill. However, what does happen, and it is happening now in Ohio, is the hormone blockers. And so you do not have to wait till you're 18 for the hormone blockers or for the opposite sex hormones. You can get those just before puberty, and about the regular time of normal puberty, you can access those. And some states are starting, and others are starting to, there's a trend moving in that direction. If you do a little extra research, you'll discover that maybe 10 years ago, there were probably 6 gender clinics in all of the nation. Today, there are 6 in Ohio, and there are 300 in the nation. And so this is a trend that is moving and getting more aggressive in transitioning children. And I think that it's just proper and appropriate for us to put up some roadblocks. We're not telling people, again, what they can do as adults, but there are so many people who regret this later on. We want to make sure, and I think it's good for the whole community, the entire LGBT community, that only the people that transition is right for transition. And I don't think that, well, the evidence clearly tells us that's not happening. Otherwise, there would not be so many detransitioners. And so we want to say, if this is right for you, do your thing. It's okay. That's not my business or anyone else's business. But let's make sure that they're able to provide informed consent before they do that.
Follow up.
Thank you, Chairwoman.
So I want to point out something pretty important. It reminds me of my personal experience. In my own agreement, I stated that I have a provision in there that I was willing to go to a hearing on and did not have to go to a hearing because we came to an agreement. I remember adding the provision in my parenting agreement, and others like Ted Hidako and other parents I have counseled to put this particular provision of no medicalization around gender. So no puberty blockers, no cross-sex hormones, no surgeries related to your sexual function and organs. And I remember my ex-husband saying, well, she doesn't want that. She actually doesn't want any of that. And my child, to be honest, I don't recall having any discomfort with her body, and currently doesn't now. She's a femme-presenting, non-binary person. So she's a girl who is feminine. So I remember that provision, and I remember him saying, she doesn't want that, so we don't need the provision. And I said, okay, so it doesn't matter if we have the provision because she doesn't want it anyway.
Wow.
So I'm going to err on the side of caution, and let's just put it in there because she might change her mind. Well, no, then we don't need it in the agreement. Okay, so you won't mind if it's there, actually, because you're in agreement with me that she shouldn't have any of these things before she's an adult. Yes, I agree, but it's unnecessary. So This whole catch-22 that Representative Humphrey is doing, where she says, this actually isn't happening in Ohio, so I don't see why we even need this bill. The assumption there is that it could possibly, it'll never happen, ever. That possibility does not exist. And we'll solve that problem when it comes around. We don't need to solve that problem now. We surely don't need to prevent something from happening because that's not the role of government. That's her idea. And if you don't have data that says that this is happening, it's possible that you could have the philosophy that, okay, there's this new thing being introduced called gender affirmative care. And let's say Liston believes this, Humphrey believes this, other representatives say there's this thing called gender affirming care. We don't actually do puberty blockers and cross-sex hormones to children under 18. It doesn't happen in Ohio. Even though we don't have the data, I'm quite certain we don't do it. So we don't need this bill. And Representative Click saying, also, if I would like to prevent it from happening in the future, if we don't think it's happening today, maybe it's not happening today. We don't know. But do we agree that we don't want it to happen? Do we agree that 18 and up is probably the decision-making time for this? So what's the harm actually in creating this piece of legislation that would prevent this from happening?
I love that he makes that point initially, but then he moves on to an educational segment, which I think is really important because when you're just starting this, you hear transition and you seem it's one box. But he makes the point, no, there's different phases of transition. And you could say, oh, they're meeting and complaining that they don't get transition, therefore transition doesn't happen. No, there's social transition that is, you don't even have to have the doctor involved. Then there's puberty blockers and cross-sex hormones, which are part of medical transition and are being given to minors. And then we can look at the area of surgery. Some surgery, such as surgery that directly involves the genitals. So whether it's castration or metoidioplasty, constructing a neo vagina or a neo penis, that is all adult. Okay. But then there's double mastectomy. And double mastectomy is something where in the W path, they are allowing people to do that. They'll say 15 or 16 years old. In Europe, there are places where they did it as young as 14 years old. And so that gray area is where all this stuff hides in. And that is primarily what this bill is trying to address, is that these hormone and specifically double mastectomy, which are happening in minors, doesn't take place in patients who cannot consent to them. And that's the crux of the issue. So I'm glad he takes that moment to educate people about that.
But can we stop for a second and say, we're talking about children's hospitals. Nobody's debating that we're talking about children's hospitals. So what exactly are they doing in children's hospitals, actually, if they're not doing medical care? There's some giant wing of children's hospitals that only has social workers and psychologists. I think I've told many parents, take a look at the staff in the gender clinic. Is there a surgeon on staff? What does that person do? And if we're just talking about people of majority age, why are they going to children's hospitals? Why aren't they going to regular hospitals where adults go? Not to say that it's not helpful to have the background of a child from their pediatrician all the way through kind of family physicians, but family physicians generally practice outside of children's hospitals. So we are talking about children.
Yeah. I think that's the question, just in terms of, are you just making this bill up to solve a problem that doesn't exist? That seems to be behind both Liston and Humphries' questions here. But he does a good job of saying, no, this is a real problem. It is happening in Ohio. Maybe not the full spectrum of transition procedures, but enough. And we're seeing a national trend where they're just adding more and more to what is being done to children, that we want to draw the line somewhere. And we need to start now before we get to the point where harm is happening that we could have prevented, even though kind of we're already there.